opportunity.
No,
I was going to say, memo to self, don't go fishing with Pat.
Did you fry him up or put him back?
No, we fried them up.
Good deal.
All that work, why not eat it?
Yeah.
My name is Shannon Saldivar. I'm from Rebel Coin Insurance in the Dalles, and I would say the highlight of my summer was just spending time in the sunshine, drinking IPAs and glasses of wine with friends and family.
Thanks, Shannon. Glad you're here. Did you come down 97 today?
Yep.
Yeah, was it a nice drive?
Yeah, it was. Yeah. Summer's always a nice time to drive.
Yeah.
I'm Laura Callie. I am the insurance commissioner and the administrator for the Division of Financial Regulation, which is part of DCBS. And it's not nearly as good as Mark's, but I got to meet my soon-to-be officially newest nephew, who is about 5 months old. I just met him about a month ago, and he is fabulous and adorable.
Oh,
Perfect.
so Cindy Condon, a consumer, and I suppose the three things. One, I just got back from sailing in the San Juan Islands, and there was wind, so that was good.
That explains the tan.
Yeah, no orcas, but there was wind, so that's good. Two, I have two sons who are not involved in a relationship, so I'm really pleased not to have a grandchild. And three, my partner in crime, my husband, just turned 65, and we both toasted that he left the individual marketplace for the medical.
A little work.
Yeah, absolutely. So that's
Great. Glad you're here. I'm Dan. My day job is at Kaiser, most of you know, and really excited to be here. I think we're going to have a great meeting. So my kid highlight was both my kids are young adults, and so we're empty nesters, and they came home. We had a mini family reunion in the Dalles, of course, with the in-laws, which was great. But most recently, you know, every year, just as an excuse to try and stay in shape, I do this little mini triathlon, also in the Dalles, ironically. And so I just did it last Saturday, and I had the same time I had when I did it in 2008.
wow.
Now, between 08 and 16, my times got way better. So I don't know if I'm like on the decline, but what I'm telling people is I'm just as fast as I was in 2008. So that's the way I'm spinning it.
That's okay, Dan. I am too.
I'm Barry Leslie. I'm the administrator for the Health Insurance Marketplace. And without a doubt, my highlights this summer have been watching my 5-year-old start kindergarten just earlier this week, and my 11-year-old start middle school last week. So it's been a fun, adventurous summer.
So hello, I'm Shauna Butler. I am an insurance broker in Lane County, Eugene specifically, with Tomlin Benefit Planning. And my highlight, just like you, Cindy, I have 2 boys not in a relationship, no grandbabies, thank goodness. But I went to Blue Pool for the first time this summer, the week before the fires started, and they closed it, and it's still closed. But I got to tell you, it's a pretty aggressive trail. I don't know how a lot of people got up there, but it is absolutely stunning, the Blue Pool. So if you ever get a chance to get up there, it's up the Mackenzie River, and nice day. Bring your lunch, because everybody goes up there, brings their lunches, and just enjoys watching the younger people dive into 30-degree water. Yeah. Ooh. Yeah. Anyway.
My name is Dawn Jagger, and I work at the Health Insurance Marketplace as the Federal Policy Liaison. And the highlight for my summer was probably backpacking in Yosemite National Park. We're huge backpackers, but I had never been down there, and it is awe-inspiring, I have to say. Never been someplace that had those mountains and those views, and it was incredible.
Hi everyone, my name is Hannah Rosenau, and I'm the Policy Director with the Oregon Foundation for Reproductive Health. I'm a guest today for later in the afternoon, but thought I would join you all day. I think the most exciting thing about this summer is I'm in a kind of ragtag bocce league, and this is the second year that me and my friend, who we've been partners for like 5 years in this league, this is our second year we won it. So.
Wow. Good job.
Back to back. Back to back. Back to back. And we didn't get very much support this year because last year we were the underdogs, and then this year we were returning champs, and I felt that.
They wanted to take you down. They wanted to take you off your mark.
They did, and it didn't happen. Now the league's done. So.
Glad you're here, Hannah.
I'm Lisa Morawski. I'm the Communication Director at DCBS. And highlight of my summer was definitely a family road trip down to Southern California.
Was there Disneyland involved?
Yes, there's Disney
Yeah.
involved for my little kids. Yeah.
So Victor, do you want to jump in? I know you're listening. Can you just tell us what, and then we'll go to the phone and then we'll get started.
Oh, sure. Yeah, the highlight of my summer, it's all work related.
And it was a highlight.
We did take a trip to Bend actually just recently. We got that just a little bit downside for the weekend. Went camping with my brother-in-law who is part of the Johnson Club in Eugene. So they came out to Bend and had this area and had a camp out at Fall Lake.
Yeah, nice. Nice.
That was a lot of fun.
That's a beautiful area. Okay, let's go to the phone. Maria, do you want to jump in and just say hi? And hopefully you didn't work all summer.
Well, that's funny you should mention that. So I'm Maria Vargas. I'm the Communications and Outreach Manager for Valley Family Healthcare. We're an FQHC over in Eastern Oregon and also serve Idaho. And I was just going to comment, if it weren't for your great stories, I didn't think there was a summer this year. It's been a busy one. But no, it's been great. We've had a lot of wonderful things happen. We opened our outreach center, which is a physical location that people can go and get enrolled into health coverage for both Oregon and Idaho, and also get connected with different community resources. And at that outreach center, one of the summer highlights was training and certifying 3 of our outreach staff as certified community health workers. So we're developing that program and very excited to be a part of that and help truly impact community health. So, thank you. I wish I could be there in person, but I'm glad that I can join you on the phone.
Yeah, thank you, Maria. We can hear you loud and clear, and thanks for sharing that good news. Joe, are you there?
I am here, and summer's not over yet, is it? I hope truthfully, the highlight of my summer is still yet to happen, and that is we're in the very final stages of completing our final home, and hopefully next week we should get the occupancy permit, and we should be able to start moving in next week.
Wow, great. Okay, I don't think Ken and Joanne have joined us yet. I do want to mention Laura Lawson is not here, and she won't be joining us. She actually has moved. Oh. She's relocated, so she had to resign from the committee. She's gone to Texas. I think it was job related. And so Barry, I don't know, is there a process for filling that vacancy, or should we just stay tuned? Or
well, so we're spreading the word to just kind of anyone and everyone who would have an interest or ideas about new folks who want to participate on this committee and would be representing the provider community. And so what I've been telling folks that I've been talking to about this vacancy recently is just kind of giving them information about the committee and asking them if they know anybody who's interested. So I would make that same ask of all of you. If you can think of excellent people in that category who we could forward on to the governor's office, love to hear your feedback and suggestions. So just shoot me an email or give me a call with any ideas you might have. And I think we're going to be trying to get a spate of names together in the next 30 to 60 days to forward along to the governor's office.
But specifically, you'd like a provider.
It does. It does. Although there's not in statute, it has to be this number of people in this number of slots. There is provider is a category, and we won't have anybody, not anybody, but it would be important to have somebody who's actually doing that direct provider.
Yeah, I think you're right.
Yeah, excellent. Okay. Jesse, did I miss anything? You want to jump in? Are we ready to jump into the agenda? Okay. Let's start. We're going to do some reports before we really jump into the meat of the agenda with Professor Corlett and then Laura. So let's start, Dawn, if we could, with you, and tell us what you know.
Sure. So I am here to report on the Basic Health Program, the House Bill 4017 that I kind of gave an overview of last time, and today is another overview. And so just, we plan on November 9th at our next meeting having a really comprehensive deep dive into what the BHP, Basic Health Program Subcommittee, has been doing. So far we have met, the Basic Health Program Subcommittee has met twice. And as a quick reminder, House Bill 4017 tasked us with updating a 2014 study that was done on the basic health program in Oregon. And so that study has been updated. There's been a draft of that. That draft was circulated to the committee members. And then we received some comments and questions that the Wakely folks were able to answer those comments and questions. And that's the second meeting, that's what we really did. We went over those comments and questions. And then we will be providing the committee members with both a DCBS policy report and the updates to the Wakely report in the coming few weeks. And then we will be having the last BHP subcommittee meeting the week of October 3rd-ish, or perhaps the following week. There's many schedules to work around. So that will be the third and likely final meeting where we really take a deep dive into both the Wakely update and also the DCBS policy report. And that's what we will bring to you guys, with lots of lead time for you to review all of these documents as well, so that you can bring your questions. And that's where we are right now.
So Dawn, elaborate on that last piece, because that's where we come into play. So you will bring back a draft report, a formal report. Tell us what you'll bring back, and then what you will look for from this group.
So the first thing that you will have is the Wakely update. So this is the document that Wakely is, that's in a close to final form, that includes, it's a big document looking into the ins and outs of what the basic health program would do here in Oregon, what other markets it would impact, et cetera. So that's one thing that you guys will have at your fingertips. And then the other thing that you'll have is the DCBS policy report. And so that will include the DCBS's analysis of the Wakely report. It will also include what the other two states' experience is with the basic health program, New York and Minnesota, who also have the basic health program. And then it will also include the comments, questions, perhaps, there's many different ideas and voices on this BHP subcommittee that may not all come to resolution. It will include all of those ideas, and then what we would like is your response to in particular, the DCBS policy report, because that will be what we turn into the official formal legislative report to the legislature. So is that helpful?
Yeah, that's helpful.
Okay.
And I want to ask one more question, and I'll open it up. So I remember, and I don't remember, I'm sort of looking at Sean, I think maybe Joe was one, but we had some folks on this group that were interested in attending the subcommittee meeting. Perfect. Awesome. Okay, so the big one is coming up, and then we'll count on those of you who are able to make that to sort of lead the rest of us who are not there through that discussion and give us the texture and the tone and help us really have a productive discussion.
Absolutely.
Terrific.
Well, because this is going to be such a meaty topic, I think what we envision is probably dedicating the majority of the November meeting. Certainly, look to you, Dan and Jesse, to tell me if that meets your expectations, and then give you lots of lead times in terms of those documents, and also have everybody here who can answer questions about the basic health program, and perhaps even if folks are interested, get you the documents enough in advance that if you even want to have us come meet with you individually or talk to you on the phone, or if you have specific questions you want to answer in advance, just so that you have plenty of time to really assess the report and get your questions answered, so that at the meeting, if you decide you want to make some kind of recommendation, you can. Because it is, I think in many ways, at least it is for me, it's probably not for this group, far more technical than our technology discussion, because there's just so many nuances to kind of the actuarial review. And if you impact one part of Oregon, then it's kind of like whack-a-mole. This other part comes out in terms of the insurance landscape. So it's just,
we have technology issues to deal with regard to the
technology issues. So there's just a lot to consider. And I think the report will be really helpful, but probably not without the benefit of just lots of time and analysis. And for you guys.
How will we engage the advocates again at this level? I know they're involved in the subcommittee. Do we envision having them back, or how should we think about that? Because I know there's strong feelings about this.
It seems like, I mean, again, up to this group, but I would think it would be helpful to let them know that we're going to be opining about this topic at the November 9th meeting, and invite them to participate in the meeting so that you can also be having a discussion with them in real time. I mean, that would be my recommendation.
Just to remind people, we have a couple of informal and formal deliverables back to the legislature. One of the informal but important early ones, which we did successfully, was the technology recommendation. I think that was good. Remember, we had a really robust discussion, I thought, in Pendleton. This is a formal recommendation that we have to give back to the legislature, along with the COFA work and some other things that'll, be in the months and years ahead. So I appreciate the seriousness. I appreciate being very methodical about it. And yeah, we'll build that November agenda, Jesse and Barry and I, to make sure that that's another robust discussion. While we're on the topic, let me just invite others. If you've got questions specific to BHP for Dawn or Barry, go for it. Cindy?
This may be a totally inappropriate question, but given what's later on the agenda, how does the BHP include a pregnancy coverage at all? Or, yeah.
So there are different scenarios modeled out, and off the top of my head, I don't remember which modeling, whether it includes pregnant women or not, because there's lots of questions about that actually at the last BHP meeting. So I can get you that answer, but I don't want to. There were many iterations, but I'm happy to write that down, and I will see what I can do.
Okay, it's just in light of what.
Mostly 185 to 200% housing level, because that's the only point at which that BHP program would pick up what Medicaid would not.
Right. I'm just wondering how that intersects with
The later,
the later topic with the people that have chosen not.
Great question.
Just to be clear about what the process on this is going to be for this committee, we're going to be getting a report, and the report, is the report going to be just sort of, here's all of the discussions that we had, now you, Marketplace Advisory Committee, should make a recommendation one way or the other, or is the report going to say, in light of all of this, DCBS thinks that we should do this?
Yeah, I anticipate that, so the language in the statute also, DCBS will be making policy recommendations as well that you will be able to read in that policy report as well.
Okay.
As long as they both come together.
Yeah.
Right? Yeah, that's going to be very helpful.
And that DCBS policy report, I'm sorry if I glazed over, it'll be fluid. It's here for you to react to and to make comments about, and for us to include all of your questions and see if we need to make certain changes to it.
BHP has been kicking around for a while. I know, Jesse, obviously, many of you know this. Many of you know more than I do, but it's been kicking around for a while. But the process is really important to bring this to closure one way or another. And so I think that's part of why we're being so methodical about, the updating the Wakely analysis, having this subcommittee, bringing it to full committee, allowing DCBS to finalize its recommendation with the input of the advisory council. And my guess is a lot like the technology state-federal discussion we had there, we won't all be exactly aligned, and that's fine. We just need to have that discussion and then report that out clearly as we did with the previous issue.
Yeah, so I guess part of the reason I asked the question is if the report says, DCBS recommends X, is the feedback from us going to be, maybe you should change this aspect of the report, but we agree, disagree, or remain neutral on the recommendation, or is our action to say we think DCBS should be making a different recommendation? Like what is, I guess that's sort of a formal question more than that.
I think the report will be more nuanced than that.
Okay.
I think it'll be more like, and much like the technology report, right? Here's the things you need to consider, and here's kind of the ramifications to each one of these major considerations, because it's so hard to think of things in a nebulous fashion. I always find it's easier if somebody kind of gives me, here's the 5 or 6 broad buckets that are going to really help guide this decision, and here's the ramifications of each one of these buckets. Like, for example, this might cost $300 million, and here's what you're giving up, or here's the decision that would have to be made, and is this really where you want to spend your money? So I don't think it'll be the advisory committee is actually going against a DCBS recommendation. I think we can be more collaborative than that, if that helps.
I would certainly hope so. And then the final question on this topic is, my understanding was that this work group, or I don't know whether it would technically be counted as this work group or a new work group, but some work group is going to be talking about the 1332 waiver process starting up as we conclude the basic health discussion. Do you have any specific plans around that yet?
Yeah, so the plan that we had talked about was kind of this subgroup and adding others as who want to participate in a 1332 subgroup will continue working after this process is completed, but it's kind of a process that we need, that they're kind of tied to 1332 and BHP, so we needed to complete this BHP work, which is due to the legislature before the 1332 work. And so once I kind of have this last meeting scheduled, we'll be able to know a more solid framework and timing for the 1332 work.
Okay. This is important, so I don't want to close anybody out if there are other questions, and also people can follow up with Dawn and Barry, of course, at any time. But we'll look forward to that in November. Thank you. Barry?
So last time when we met, I know Chicky came to our meeting in Eugene and just kind of updated everybody about the different things that the advisory committee and that she as the program manager were working through to get this program ready by November 1st. And I just would welcome Sean and Shannon, who are on the committee. The COFA. I thought you were on that one.
No.
I know Sean is. Isn't there someone else
You
on
could
that
be.
too?
Not too late.
Joe? Oh, thank you. It's Joe. Okay. Well, anyway, Sean, please jump in if there are details I leave out, because I know you guys have been doing a lot of work on this. But I know that Chicky updated us last time on kind of our work in two different buckets. One, to really finalize our outreach and education efforts and to really get that underway and make sure that we were on track, to make sure that the community actually knows about this opportunity when open enrollment kicks off November 1st. And then the second bucket was really a ton of administrative details, which are not always fun and not always interesting to talk about, but as we all know, when you're implementing a program of any size, there's a tremendous amount of administrative details. So the good news is she and the subcommittee have made a tremendous amount of progress on both fronts. At their late August advisory committee meeting, they were able to review all of the work plans and strategies that the new community partner grantee, which is the COFA Alliance National Network, they're going to be taking over the official community partner grant to do the outreach and education for this kind of enrollment population. And so the subcommittee had a chance to really kind of help finalize all of their outreach plans for the next few months. And in the subcommittee report, she provided just a lot of specifics for those who are interested about the kinds of things that they're going to be doing to make sure that they're reaching this population, because there really is a very particular way to do outreach in the COFA community, and just to have their expertise is going to be hugely helpful. So that's on track and going really well. The other bucket of work is just really administrative, and as you can imagine, there's just a lot of getting application materials ready so that we can be accepting applications beginning October 1st. We had huge concerns about making sure that the reimbursement process for the in-network out-of-pocket cost is not overly cumbersome for the customers, because this is, this could be as few as 400 people, as many as 1,500. So you really can't spend a lot of money administratively on something that has this small of a population, but you absolutely have to have something that is easy enough that people won't be like, well, I don't want to do that because I won't get reimbursed, or I can't afford to put up the upfront cost. And so Chicky has done so much work and finally was able to find a partnership with U.S. Bank. Because they're a state contractor, they're willing to work with the smaller program and make it feasible at no charge for us to use their, what they call their Relia card, kind of a debit card system, so that we can load reimbursements onto that, and there won't be any kind of upfront startup costs for the customer. So that was really good news.
Don't undersell that. That's
No,
great news.
no, and it's kind of like, oh
exciting.
Gosh, reimbursement issues, how interesting. And I know it's not, but it's really like the core. It was the biggest problem. Yeah. And we had initial conversations with different credit card companies and just hadn't found the right fit in terms of a vendor who is willing to work with us. And again, sizing this is really important, because you can't spend tens of thousands of dollars solving administrative issues on a small program, but you really have to have a good enough system that it works well for customers. So that was a big win, and just all kinds of other small things like, making sure that we have database systems to be appropriately collecting private information, because these are going to be people we're working with, making sure that we've, worked with OHA to ensure that the Medicaid eligibility has already been resolved before they start in their application process. So just an amazing amount of great work the committee's done, and everything's really on track. Chicky keeps reminding me that something is going to go wrong, and so I think just because there's just so many moving parts here, but to date, all of the big problems that started at the beginning have really been resolved, and I think there's good solutions. So with that, I leave you lots of detail in the official subcommittee report, but Sean, any feedback or additions?
Not particularly, that's last bit about the debit cards is actually news to us, even.
Love breaking news, I know.
That was really exciting.
Yeah.
Yeah, exactly. We're there.
Well, yeah, thank you to U.S. Bank, because there's almost literally no way to make money on this thing because it's so tiny, but obviously it goes without saying for the people involved, it's critical to the success of the program. So, good.
Just a quick question. Again, it's probably because I'm newer to the language. So, will the BHP program be available for COFA? Is it a qualified health plan is named in the COFA step, but if there's a BHP offered, does it?
I think there's what if they fall into the income bracket that the BHP serves?
Okay. Okay.
138% of the income bracket, as well as people over 65, whenever we go into basic health plan, whereas we go for
Yeah. And I was just the designation, you know, because in the COFA notes it says specifically QHP. So
yeah.
Just curious.
I'm sort of curious if you've learned anything through doing this COFA process about how something like a special enrollment period for pregnant women might be feasible, even though we have the federal requirement. So maybe that's for later, but I'm just curious because I sort of saw COFA as like a first stab at. So I think
we've learned two things, and actually we've learned a lot from enrolling a lot of co-op members into new plans this summer too. And Sydney and I had a good chance to download about our interactions with the FFM, because I've now come up close and personal with lots of FFM operators. So I guess two things. One, that if it's a small enough population, we can do almost anything, because even if we have to manually do things, if we can't automate them, we can get it done. And so I think there's the good news is that means that with a small enough group we can do anything. The bad news is you don't want to always turn to manual processes, because after a while what you have is so little automation that you become terribly inefficient, and then the customer starts to lose too, because you actually can't manage the process efficiently. So I think what we've realized is we can be creative and flexible within small operations, but I also think we're going to know a lot more, because we're going to know what we didn't think of as soon as we start enrolling people. So probably by February or March we'll have a lot more aha moments. But those are
things for that, just because I don't want to forget this when we get, and I don't think we will when we're talking about the special enrollment for pregnancy. The one difference in that COFA is kind of a step to learning more about how we could serve pregnancy with special enrollment periods, is that the COFA population can enroll on healthcare.gov right now, and so it's a population that we can have that automated. And the special enrollment periods, it's not an automation that healthcare.gov selects. So it's a little bit different there. Exactly. So we have that kind of framework already with the
kind of a major policy distinction.
Right. Yeah, and operational limitations, unfortunately. But I'm sure we can.
You know, it occurs to me when we get to the point of talking about the special enrollment period, we might want to consider, even though we know the answer would be no, whether we might want to propose 1330 waivers for some of these kinds of issues, so that we can gather actual denials with actual reasoning from CMS to sort of help build a case for, you know, legislative action or whatever, you know, whatever the case might be. But right now we kind of sit around and nod our heads and say, yeah, you know, they'll turn it down because of this, but having an actual decline in hand might be worth the cost of pursuing the actual waiver.
Well, especially since we agreed, I think, to the legislature to track and plan to track what specific things we can't do, because we're sticking with the FFM for now. So it's a good idea.
Jesse.
COFA-related question. At the meeting in Eugene, I remember Chicky saying that you were thinking about hiring or bringing on some health translators to work on the program. Is that still something you're working on? And what's going on with that?
Yeah, she's been doing so. Every time I talk to her, I'm like, where did you have time to do this too? She actually partnered with the Department of Human Services, and I think it's their Office of Equity and Inclusion, to essentially create an opportunity, particularly for health insurance agents who are bilingual, but also community partners, to actually take this health translation services training and have DCBS help sponsor it so that we essentially build kind of an army of folks who can do this work. So that's very much underway. And what she's kind of built the partnership and laid the groundwork, and the next step is really to get the people who want to actually participate and make sure there's enough interest from agents and others to actually receive that. It's really a certification.
More for community members as well, not just the agents and partners. Anyone who's the health literate translator.
It's a big time commitment, and so I think Chicky's more optimistic than I am that there will be citizen volunteers who are interested in doing that. I hope there are, but I think it's something like 80 hours of training, and it's a significant.
Something, I think it's 4 years, something like that. Okay. It's a good chunk of time that they're giving. It's a stipend, and it's a good chunk of
great opportunity, though.
Yeah.
Does that mean that the funding for the program is going through the Office of Equity and Inclusion? I know that there was a possibility that Chicky was going to come back to us with a question about budget for this.
We are sharing the cost of it, but I remember in terms of just the actual training cost, but I remember it was minimal. It wasn't a big earmark item. I mean, I think we were talking about in the 1,500 to 3,000 range in terms of just sharing the cost of the trainers.
Documents said 3,000. I don't know what it actually spent. So.
Yeah, it was not an amount that I thought I better get broad approval.
Fair.
Just writing checks all over the place.
So let me try and land the COFA discussion. I don't want to preclude any final questions. Okay, great. Barry, anything to add on that, or it sounds like things are going smoothly? Yeah. That's terrific, and I'm sorry we didn't have Chicky here in person, but it's great to get that update.
Yeah, she'll be back.
Okay, so we have Lisa Morawski filling in for Joel. Appreciate that. That comes with the usual caveat, which is don't pepper Lisa with any detailed questions, which you can already tell the group is into the details.
Well, and actually, I appreciate Joel is on the phone. We weren't sure if he would be, and so he can tag team with Lisa.
Exactly. Excellent. Yeah. Lisa, do you still want to take the lead, and then Joel can
I can do that.
chime in?
Yeah.
Okay.
Oh, thank you.
So let's do that, and let's ask you maybe about 15, 20 minutes.
Oh, yeah.
Run through it. We'll have time for questions, and then.
Okay. Yeah, and feel free. We have time. Feel free to interrupt with questions, or if you have feedback or input. I think that we really want to get any new ideas or input from the group today. So this is an overview of our outreach campaign, which is starting very soon. This open enrollment is around the corner. So you'll see from here, we had a successful campaign last year. So you won't see any major overhauls or anything like that. I think that it worked well. We're not going to reinvent the wheel. We're just kind of refining as we go this year and taking lessons that we learned from last year. And trying a couple new things, but for the most part, it's pretty consistent from what we saw last year. So open enrollment starts November 1st. So the campaign is going to start November 1st and run through the end of October 1st. The budget is the same as last year. Our goals are also the same as last year, basically maintaining our market share, getting people to actively re-enroll, instead of just auto re-enrolling with the current plan that they have. So really getting people to understand that things change from year to year and plans are changing, prices are changing, and they need to really look back, look again and see what they need. And to continue to build trust among Oregonians that we can help them by providing good information and connecting them with help. I think that, we had some good gains last year in enrollment. This year, we think if we can maintain that market share, that would be successful given some of the market changes that I think Laura will be talking about. We really want to make sure that people who are insured stay insured this year, and of course stay with the marketplace and get financial assistance.
You're going to leave the bad news part to Laura.
Absolutely.
Yeah.
Absolutely. Yeah.
A little assistance there.
That's why she gets the big bucks.
Totally. Yeah. So, and like last year, we have key performance indicators for each of those goals that are more specific about numbers and different segments. So we will be tracking those throughout open enrollment. The messages are probably going to look pretty similar to last year as well. One thing that we're going to try to emphasize more on is the free local help. We found that we were enrolling people in the co-op, as Barry alluded to. It's really difficult you know, particularly if you're losing coverage with, which a lot of people in the rural areas are going to be losing their particular plan, the opportunity to re-enroll in their particular plan. And so just kind of understanding what all the options are, what you're eligible for, is complicated and it takes some time. So we're really going to focus this year on pushing people to the agents and community partners that we have available to help. Another maybe of an emphasis a little more than last year would be on the penalty as it's been increasing. We found that that's pretty effective in motivating people and actually tying it to a dollar amount so that it's a tangible number. So you'll see that in messaging as well. And then here are all the tactics that we're going to use. And again, these are pretty similar to last year. You know, with the digital advertising, the great thing about that is that you get real-time data on it so that we can really use that to look at what was the most successful last year and focus on that this year. Some of the areas that we are expanding on is video. Last year we mostly just used video on Facebook, but this year we're going to be doing video on Hulu to reach more young people. We did some focus groups over the summer with millennials and Latinos, so we're using some of that feedback to drive some of our tactics this year. So we also are going to be focusing more on Spanish and Latino, both earned media and paid media. We're doing some more work with Univision this year, and then continuing to try to get some earned media coverage as well. And then we, like I said before, we are emphasizing more on the local help available. So we have increased the number of agent storefront grants that we're giving out. So we did 24 last year, and we're doing 35 this year, and also increased community partners from 4 to 6. And so that's going to be really key, I think, throughout this campaign, is to really push that. Last year I found that the best media coverage, free media coverage we got was through our agents and our community partners, which was just great. You know, we gave them some tools and a little bit of training and just said go out and, you know, talk to your local media, and they did that, and we got some great coverage. So we really want to continue to really focus our, at least earned media efforts on getting them what they need to be our spokespeople out there. Any other questions on these tactics?
I'll jump in, and I want to make sure you are able to get through this, but you know, we're going to have a big conversation later about sustainability of the marketplace, and that's really, at the end of the day, what we're all here for. And a lot of that deals with carriers and other, you know, technical things that Laura will be talking to us about, but it also depends on our ability to continue to drive a growing risk pool, a diverse risk pool, millennials, Latinos, and others. And so you may get, either today or sort of in the coming weeks, you may get some questions real specifically from me and others about what are we seeing with millennials, what are we trying, you said real time, we have a 3-month window, how are we adjusting on the fly, because not only is it a nice to have, it's imperative that we're successful here. And I know I'm preaching to the choir, Lisa and Joel and Barry, but you know, we're all really invested in the success of this because it really relates directly to the success of the marketplace long term. So it's great to see the diversity of, you know, you're not relying on any one thing, and it's great to see you incorporating the mid-year learnings from the co-op, and so thank you for that. But I'm sure you'll have a lot of specific questions and a lot of suggestions from all of us about what else we could be doing.
And what's interesting about that, Dan, I think you're talking about kind of a different focus too, whereas last year we really want to maintain our numbers, and then we kind of blew the numbers out of the water, and that just felt great. This year it really almost needs to be about, we need our numbers to look different. We need the people who've enrolled. I mean, we definitely want to keep the folks we have, but we need to be seeing some increases in those specific populations. So it's almost a different goal in a way.
There was a great article in the Portland Business Journal, some of you may have seen, about Latinos especially, and about getting rid of some of the assumptions we have about Spanish speakers, you know, or people who are documented versus undocumented. So there's really a robust community of Latinos out there that we need to reach that may use Spanish as a primary language, but may be ready and able to come to the marketplace, and let's go for it. So I'm excited to see that highlighted up here. Shauna.
I just wanted to jump in, having some contact and interest in the Latino community myself. What I've discovered is while you can describe the need for the insurance, you can go through the marketplace, and I'm talking about, you know, people who are here legally, you can get the tax credit, but after several months, and Dawn and I had spoken about this at the last meeting, and they don't use the insurance, they don't feel like continuing to pay that amount every month. It doesn't communicate with what's going out of their resources every month to what they're receiving back.
The value proposition, they don't perceive.
Yeah, cost benefit, right? So that has been my biggest experience, is the attrition that happens within the Latino community.
Great observation.
Well, just to
Hey,
follow
Dan.
up on that.
Yeah.
Hey, this is Ken. I
go
just
ahead.
wanted you to know I'm on the call.
Ken, we appreciate it, and we're going to come back to you later, and you're going to have to do the icebreaker that we all did. But in fairness to the others, I just sprung it on them. So I'm going to spring it on you at some moment in the next 2 hours.
Awesome. Great.
Cindy, go ahead. No, we'll call you.
So just following up on that, just from not a Latino population, after the last meeting, I came home and I happened to talk to my millennial son, and I said, I hesitated asking you this question, but I'm hoping you have insurance. And he said, no, the application was too, I couldn't get through the application process. I got so frustrated. And he said, and you keep saying that I get a subsidy. I don't get a subsidy because the plan I want is a bronze plan. There is absolutely no value for me. Now, I would have loved to have proved him wrong or said something. I don't know how you market to that. And so I think all this is great, but I'd be interested in the message, because I think that's a huge barrier.
These are independent of whether or not the bronze or silver plan.
Well,
Yeah, cost sharing is what's dependent on.
Yeah.
well, I told him he was wrong, and then it was a silver plan. I mean, he could get a subsidy if he got the silver plan.
And that was a reduction.
Well, you can walk him through that, because you know, I had to tell him, okay, I get what you're. Yeah,
I had
which could be, which
Like
look a lot like
and it is a bronze, and it
Yeah,
probably
it is
pops
a-
up first for somebody
That's
who's
exactly
under.
right.
Yeah,
I mean, it was clearly no subsidy.
Yeah,
So if you can
catastrophic
show me
plan.
something, I'd love to see it.
But I think what you're talking about,
Catastrophic, I don't think.
But if he qualifies for a subsidy, he should be able to get something that would cost less than a catastrophic plan or a bronze plan would.
Ooh, okay, maybe that's the deal, to go to
Without
a storefront,
subsidy.
I guess.
well, I think that's exactly what you're speaking to is exactly the point, Cindy, which is we're targeting a population of millennials. So you're actually focusing on people by age group, which is really tricky, because it's not as if it's not a faith-based outreach, it's not a cultural outreach, it's actually an outreach based upon people in a specific age group, which can look, I mean, we all can look different regardless of our backgrounds, but it's hard to reach. And so, Joel, I don't know if you want to pipe in on some of the specific millennial outreach we've been thinking about.
Can you hear me?
Yes, go for it, Joel.
Okay, sure. So, I mean, all the issues you've been discussing are ones that we are very aware of, and more aware of because of the co-op when we had to sit on the phone with the FFM for many hours every day. The problem is that barrier to entry there, and regardless of whether they're young adult or they're Latino or even our existing customers, the local help is the one tool that we have in our tool belt to really overcome that. And I think that's the driving reason behind why we're interested in more storefronts and using those folks, that A team of agents and community partners and assisters out there to help people navigate that process. And we've also seen that, okay, it's very true, you get them in, and then you have this issue of attrition, which actually hasn't been much different year to year, but it's still a lot of people dropping their insurance over the course of the year. But we see less of a drop when people have somebody like an insurance agent or a community organization that they can go to and talk about difficulties or see if there's solutions to what they're dealing with. We tend to have higher retention and re-enrollment rates when somebody has that personal assistance. And so Get Help was one of our #1 messages last year, so we're going to re-emphasize it this year. We're redoing the website to provide more options for getting assistance. We're going to test pilot a live chat feature. We've redone the Finder tool on our website and are continuing to improve it. We have another version planned before open enrollment. It's all in an effort to drive people to somebody who will help them not just get a plan, but get a plan that does get them that financial assistance, does help them answer their question, and then helps them get through that entire enrollment process and the payment process, which you can lose people at any of those pain points along the way. So that's our overall plan, and then we're trying to pick tactics and strategies that support that, trying to reach different audiences different ways. Elise has gone over a few of those, but that's the overall gist of what we're trying to do.
It's interesting. Yeah, Joel kind of referenced the live chat, and so many of the things that we're learning and realizing about this population is that the expectation of kind of the Amazon environment is really also the expectation of how you enroll in health insurance. And agents, because of some more simplified, efficient processes that agents can use and that we can streamline that process and get you through more quickly. But a lot of folks in this demographic actually don't want to work with someone else. They want to go online. They want to do it quickly. They don't want to have any kind of, in-person or even over the phone conversation with anybody. And so we're exploring lots of other ways of kind of making it easier or being online or answering questions. But we're just starting to kind of get our feet wet with all of that. And at the same time, you can't avoid always the FFM. So.
Silver plan choice is probably the biggest difficulty there. There's some Cancer Family Foundation study about 60% of enrollees in the healthcare marketplace get some amount of help from a community partner or other agents or anything like that. And at least those agents are overwhelmingly enrolling people in silver plans. We very rarely do anything else, but most of those marketplace enrollees who choose by themselves go for bronze plans. So that's the biggest difference there, and making sure people realize that silver plans probably lead to their benefits if they're qualified for any level of subsidy from the cost sharing reduction.
And that is a big
messaging that point is complicated.
It's a hard one, and that's where it sounds like, at least in person, your son sort of hit that wall of understanding there.
Well, and I did too. I mean, I went and said, no, I know it's here. And
the FFM has one line about you're eligible for cost sharing reduction, but it doesn't really explain what that means when it tells you that you've got them. So
as marketing methods to millennials, they'll like mom telling you you're wrong.
Right.
Isn't probably
He was quite proud of it, I will say. Yeah. Lisa, let's jump in, back in, please.
Oh,
sorry.
sure. So.
Oh, Jim, go ahead. Sorry.
Okay, so what I'm wondering is the outreach team making contact with the hospitality industry and building trades industry trade groups, because I think a lot of the people that we're focusing on here, that's where they're going to be working, whether they're younger and lower income or whether they're in the other social economic groups. And for example, in Cover Oregon, director or something of the, I think it was hospital and restaurant trade group was involved in that. It seems to me if you get some buy-in at the workplace, you've got people who can, management staff who can help coach people, counsel people, be a resource if they're informed, if they're up to date. And so if we get the trade association to work with their members, you might gain some more penetration through that.
Jim, I think that is an excellent point, and we started doing some of that last year and have continued. For example, I think I reported to this group when we were out there talking to folks about the opportunity of SHOP. What we actually learned from employers, particularly small employers, is that what they really wanted was us to partner with them and help them educate their employees about purchasing insurance on the individual market. So our primary small business outreach, and we actually have 2 full-time people now who are working in the Agent Small Business Program, both named Michael, just to be really confusing. That is their focus, is partnering with business associations, trade groups, small employers, and really making sure that they know about the marketplace as a tool, and then providing them with actual information that they can then pass along to their employees at a weekly staff meeting or something that really explains the opportunity. But we also have our outreach team, which you folks have heard about, and this is the team that is kind of by tasking in terms of they can answer the phone when we're busy on the phones, but they can also be out in the field meeting with different business associations or doing outreach to community colleges, being present at Comic-Con or half marathons or things where millennials might be hanging out, which is a big target. But one of the things we realized is in a couple of the counties where we have outreach folks, they are heavily emphasized along the coast, for example, in that kind of seasonal tourism hospitality industry. And so that was a primary target last time, but I think it'll be even a bigger target this time, because I think we're kind of able now to refine some of our areas where we probably have the richest opportunities, both for this age group and also people who will need insurance. So I think that's a great, great reminder.
Great. So I think we've talked about, this is the last slide, and just some of the things that we are going to be focusing more on and emphasizing more in this open enrollment period and constantly targeting. And so that's the more local help through agents and community partners, Latinos and millennials, which we've talked about. Also really providing support for rural audiences who have limited options. Again, with the co-op situation, if you're losing the option that you're familiar with, it's really difficult to kind of figure out what to do. So we want to focus on that. And then similar to what we did last year is with the paid media, really targeting the counties that have the largest numbers of eligible uninsured folks to get the most bang for our buck and to make the most impact for them.
I have a question that's way deep in the weeds, but something I've been thinking about. I heard that CMS is going to be doing this new thing this year where they crosswalk people whose plan is ending or being discontinued to the most similar plan that's available on the marketplace, and they'll be sending some sort of communication to people who are in that situation. And this has created a little bit of controversy because it's been described as an auto enrollment system, but it's not exactly meant as such. But I'm wondering how, because there's actually probably a lot of Oregonians who are going to be in that position because maybe they were enrolled in MODA, one of the counties that they're pulling out of, or there's a bunch of insurers that are shrinking their footprint. Have you seen what the communication around that is going to look like for those consumers or anything like that?
So I'm happy to. I've had several conversations with CMS about that communication because they don't quite have it laid out yet. They aren't able to, I guess there's 2 paths of communications that I've taken with CMS. One is, how are you communicating this enrollment to the issuers and to the carriers, and what will their role be in helping communicate, if any, to these people who are auto-enrolled with a new plan, with a new carrier? And then the other is, what types of communication will you be doing to this particular population of consumers? My understanding is that tomorrow I'm supposed to get that CMS is giving a presentation to carriers to talk through that process. So unfortunately, they just haven't nailed it down yet. And then kind of the same thing with the consumers. The CMS intends to have email blasts after December 15th to this particular subpopulation who have not actively re-enrolled in a new plan, but that's kind of the only specifics that I've been able to get out. I don't know if Laura's heard more or anything, but I'm really hopeful that tomorrow that I'll have a lot more information that we can absolutely share, and I can provide some sort of summary.
Part of the reason I'm curious about this is that it seems to me, I don't have a problem with CMS trying to help people who are in that position, but I wonder whether the crosswalk is actually going to be identifying the plans that these people would want to be in if they were to go back to the marketplace themselves, and that would be the ideal outcome. So I'm wondering if there's going to be some sort of communication saying, you really ought to go back to the marketplace, but if you don't, we're going to crosswalk you to this plan.
So I think that's the first messaging always with both that we're messaging and that CMS messages, which is you need to shop because you can save money by doing that. And so it's always shop first. And I think Oregon had our percentage of re-enrollment from last year was really high for those who actively re-enrolled. Higher than national average is my recollection. So we're really hopeful that either the message got through or the consumers understood, and that we can see that similarly this year.
And it's a tough kind of consumer balance decision too. Do you want to risk losing them by not picking a plan for them, but then also risk really irritating people by picking a plan which they may not have chosen for themselves? So, I mean, it's really like, how many Oregonians are there? How closely can we align the plan? What will the communication look like? And then kind of making a decision based on all that.
And I think there's kind of an added piece, kind of representing the regulatory side of DCBS. We've talked about not just inserting ourselves in a consumer decision, and they may not be clear what is the closest plan, and then what decisions are we making that are actually affecting exposure for carriers from a regulatory standpoint, and are we picking winners and losers? I mean, so it's just a really interesting question that we've tried to wrestle with a bit, and we absolutely see the value in helping people not fall off a cliff in terms of making sure they stay covered, but how do you do it in the best way, in the most fair way to everybody? It's really challenging.
Good. Any other questions? I want to give a chance for Lisa to wrap, for Joel to chime in, other issues, other concerns. This is a big one, Jesse and others. Thank you for bringing that up. And I should say, with my Kaiser hat on, I went through a little deep dive mapping exercise with the staff, and it's complicated, and as Barry captured, there's 2 ways to win and 2 ways to lose on each mapping. Lisa?
I don't have anything else, but if you guys think of anything else after the meeting, feel free.
Joel, anything we should have covered? Lisa, appreciate you jumping in.
No, nothing from my end.
Okay, Claire, go ahead.
Sort of last thought. In the Medicaid world, we've had, a whole new market, a whole new batch of folks that are newly insured, and a lot of them don't use their insurance. They don't get health care. And so we've been struggling with that. And so when I think about the value of buying health insurance and how much, I think when you're sitting with an agent, you're getting a nice sort of overview of the types of services you could use, but I think a lot of folks, perhaps millennials and Latinos, who are not used to using a primary care doctor, are they still just going to ERs? And then that's kind of skewing the way we don't want for utilization. So just, is there any way more to do a little messaging around the types of services you can use once you get this insurance, and what is appealing to a millennial or a Latino individual, and sort of angling for motivation in that way, and then scare them with the horror story. But so just thinking about that after you get the insurance piece as well, and what the value can really be to folks.
I think that's a really good point. I've had conversations with several legislators, especially when we were going through the losing carriers in rural parts of the state, and it led to conversations about, in their case, generally older constituents, like fairly large premiums they had to pay, and what they were getting for that, and the general perception that they weren't getting anything for it. That if, unless they got really sick or really injured, they weren't getting any value at all for it. And it kind of ties in with the comments that relate to the did you pick the right plan issue, but now I'm paying all this, you hear this meme, now I'm paying all this money and I still can't go to the doctor. Well, you actually can go to the doctor, right? And I think there is potentially a big piece of work for us to do around the basic value proposition, that you're getting valuable stuff that you can use now, and you're getting even more of it if you pick the right plan, right? But that you're not just paying however much per month to avoid a penalty. You're actually getting a valuable thing for it.
So to that end, last year after open enrollment was over, we breathed a sigh of relief and then kind of said, okay, well, what are we supposed to do the other 6 months of the year? Like, you know, what do we do in between open enrollment and when people really aren't paying attention? Because you really, as Joel has trained me to think, you really want to sell people a message at a time when they can act on it. Otherwise, they're not going to hear it. And so we developed a whole bunch of messaging to be doing outreach with people at times when they could actually receive it and might take action on it or it might mean something to them. So we've tried to do right after, like in the February-March period, try to do that. Now you got insurance, how do you use it? And then we've tried to do the, okay, you're getting married now, and what does that mean in terms of changing your insurance? Or you just had a baby, and what does that mean? And so really trying to educate people at a time that's meaningful. I think in any kind of literacy outreach, that's always the most impactful. But I think it's still not an exciting topic that really resonate with. So we still have a lot of room to grow in terms of refining that effort and actually reaching people, because we're kind of noodling around the edges on it and we have a framework, but I think in terms of actually having impact, we have a long way to go.
We have a lot to talk about. I don't want to take up too much more time with this, but do you have any sort of theory about why those counties are the counties with large numbers of eligible uninsured? Like anything having to do with demographics or because I mean, one of the things I've noticed in following the numbers around this is, you know, there's some places that I thought were going to be real sort of trouble spots for ACA enrollment that have not been, like Southern Oregon, for instance, has a higher enrollment than you might have expected. So, you know, why is Southern Oregon higher than you would expect, and Deschutes is on that list, for instance? I have no idea.
That list is such a mix of rural, not super rural, but somewhat rural. Of course, Nome, Clackamas, Deschutes, but you've also got Clatsop, Lincoln, Columbia, and Lynn, and Polk. So
I think some of it's about actual population opportunity. I mean, I think the metro ones, it's about that. And Joel might want to jump in here. I think in a couple of them, Tillamook and Clatsop, we've talked with our outreach coordinators about just there are some some significant poverty issues going on there. But Joel, any thoughts about Jesse's question?
Yeah, just to follow up with your example there, those last two counties. In one, we tend to have a really close-knit structure for community partners and organizations that help share the message and get the word out and then assist people in terms of actually accessing care. So, and you can have two counties right next to each other, and if there's a network of people to assist in one and not in the other, you can have a huge disparity in terms of people getting enrolled as well, and that's what we think is happening there along the coast. Tillamook has a great network, and we're always invited to go do events there, and then just, you know, up the way, it's completely different, and you tend to run into those issues of people not being insured or not being able to use their insurance. So I think that speaks a lot to, you know, not just things that we can do, but making sure that there are networks in place and helping that in those sort of places. And that's how we really kept an eye towards that when we were awarding our grants for agent storefronts and community partners, because we were aware that was probably a large contributing factor. You know, it's obviously not the silver bullet. As Barry said, there are many reasons why you'd have enrollment higher in one than another, but it's something that we can actually have an impact on if we make an effort.
I just wanted to make a comment, and I apologize if when I stepped away somebody else spoke to this, but there was the question of what is it about those counties? Part of my background is a bunch of years in economic development, and when those are the counties that have not high percentages but large numbers of uninsured. Once you factor out the counties that are on the list just because they're big, Portland, Clackamas, Deschutes, a lot of the rest of the counties are counties where if you looked at people's family income, it tends to be cobbled together from lots of individual little sources. They'll do a little logging and a little fishing and a handyman work at a hotel and lots of little pieces of income. And I don't wonder if there's some relation to kind of the tenuousness of the income to your willingness to commit to that kind of an expense that characterizes those.
like Clackamas is very different county to work than Portland. I imagine a lot of the range uninsured in Portland are going to be immigrant communities. Language access being a primary barrier, where Clackamas is more of the access to services because things become so spread out, but it's still within Portland area. So it's, the network of community partners and all that's much weaker in Clackamas than it is in the other counties, but the language issue is not as much of a factor there. So just each county has its own specific jargon.
Very true. Yeah, it makes me wonder, Pat, what you said, taking me all the way back to Jim's comment about an industry-based outreach strategy, if there's a way to access some of those part-time or highly transient industries like food service or hospitality where people are coming and going and maybe just working seasonally, that sort of thing. But that's probably too detailed for here, but it just lets you know what the depth of the challenge is here. And I'm excited to see what we're able to do this year. So we're at time. Victor, I don't know if we can tell if Dr. Corlett has joined us.
Yes, hi, I'm here. And
terrific.
Sabrina Corlett.
Oh, I appreciate that, Sabrina. Okay. So what I'd like to do, since we have her on the phone, she's on East Coast time, I'd like to introduce her and have her go ahead. I know the food is over there, but we'll do some time with Professor Corlett, and then we'll take a break, and we'll switch over and let Laura walk us through some of the local challenges. So let me quickly just introduce Professor Sabrina Corlett from Georgetown University. She works at the Center on Health Insurance Reforms. She actually came to my attention because Jesse O'Brien, our vice chair, circulated an article that Professor Corlett had written. And what was obvious was, even though her article was about a specific proposal related to Medicare, she had a good background and understanding on sort of the national perspective on what's happening in our national insurance markets and especially the state exchanges. And so our hope is here, and we haven't given her a ton of time, our hope is that she can really just sort of give us a sense of what's happening nationally and give us some national context to the challenges that we're facing. And then as we're walking through the presentation with Laura, that'll give us the national context. And as we're thinking about ideas where we want more information or where we want to explore some ideas, we'll have that, that national framing. So with that, Professor Corlett, what I'd ask you to do maybe is just introduce yourself briefly. Let us know sort of your area of expertise, your area of scholarship, if you would. And then what you have here, I think you talked to Barry, you have a good sense of the committee, so we've talked to Professor Corlett. She knows what the committee is, what our objective is. She's seen our agenda today. She knows we're trying to get a sense of the national framework here. And so in the interest of time, after she introduces herself, we'll just ask her to jump right in, if that's okay. Okay.
Absolutely. I'm delighted to join you, and both Barry and Jesse has given me a little bit of background on your committee, and I've been very impressed with all of you and your backgrounds and what you're bringing to this. And I actually jumped on the call about 15 minutes ago and got to hear some of the conversation, and you're clearly wrestling with some really important issues that will directly impact consumers. So kudos, hats off to all of you for your work. I am at Georgetown University's Center on Health Insurance Reforms. I primarily study private health insurance and how it works, how it's regulated at the state and federal level. And needless to say, we've been studying the impact of the Affordable Care Act for the last several years now. Laura, Callie, and Barry know the Georgetown folks probably pretty well. We're constantly bugging them for information about what's happening in Oregon. And we actually do the same with all 50 states. So rest assured that as much as we're bugging you guys for information, we're doing the same with every other state to try to get a picture of what's happening nationally. And that's what I'm here to talk to you a little bit about today. And my overarching message for you all is that Oregon is not alone. The health insurance marketplaces created by the Affordable Care Act are evolving, to put it diplomatically. So I'll talk a little bit about some of the bumps that we've been seeing and that seem to be on the horizon. First of all, moving into 2017, preliminary analyses of rates and issuer insurance company announcements certainly suggests that issuer participation is going to be lower than it was in 2016. As you probably all saw, the big news at Aetna, which is a big national carrier, announced that it will pull out of 11 of the 15 marketplaces where it has been offering coverage. United is reducing participation from 34 states to 3 or fewer. And Humana has announced it will also reduce participation from 19 to 11 states. Of course, we're also hearing about exits from smaller carriers, local carriers, as well as some of the new companies that came into the market in the wake of the Affordable Care Act. Oregon, of course, has experienced the unfortunate demise of the co-op plans, and that's has played out actually in 17 states across the country. We're now down to 6 co-ops with the recent departure of a co-op in New Jersey, as well as again smaller carriers, you know, from Indiana to Wisconsin to New Mexico and New York and Texas, local regional carriers that are just pulling out. A recent analysis found that in 2017, about 19% of enrollees will have just one choice of insurer. That's up from 2% this year. So it's a pretty big jump in folks that are getting much more narrow set of choices. You know, insurers will cite a number of reasons for exiting these marketplaces. They include lower than expected enrollment and as a result sicker than expected enrollees, inadequate compensation through the Affordable Care Act risk mitigation mechanisms, particularly the risk corridor and risk adjustment programs. And then they've also pointed to concerns that, for example, some providers are paying the premiums for some very ill, chronically ill patients and directing them to commercial products, leading to, again, a worsening of the risk pool. Some gaming of special enrollment opportunities, as well as the 90-day grace period for the non-payment of premiums as being an issue where people might be jumping in to get healthcare services and then jumping out, which harms the risk pool. Some carriers that are staying in the market are raising premiums, some of them significantly. Again, Oregon is not alone here. You know, for example, Minnesota has announced. I'm sorry, did somebody have a question?
No, go ahead. That was just a technical glitch. Keep going.
Oh, okay. Minnesota has announced proposed rate increases between 36 and 67%. New Mexico has approved rate increases ranging from 23 to 93%. New York has approved rate increases between 8 and 28%. Again, all the rates are not final across all the states, but you know, an estimated average rate hike people are seeing is between 24 and 26%. Again, not final. Not all states have released their final rates. So, you know, this all begs the question of, you know, is this a one-time correction for underpricing, or are there more systemic issues at play? You know, my general belief, and it's a strong belief, is that the ACA's structure of insurance reforms is fundamentally sound. There's no reason that the exchanges can't be successful and sustainable over the long term. We have a requirement that people maintain health insurance coverage or pay a penalty. We have a subsidy structure that I think guarantees that there will always be people in this market, and so at least in theory there should be carriers willing to serve that market. And some carriers certainly are making it work and reporting that they are making money in this market. And those that are making money are pointing to their marketing strategy, their network design, and their utilization management as key ingredients to their success. And even, you know, Aetna and some of the other companies that have reported big losses They have noted that, while their traditional plan designs may be losing money, they have reported that products that have narrow networks and focused delivery systems appear to be performing well. So I think what we're seeing is a sign of market forces at work. Some carriers are figuring this out more quickly than others, but it will certainly take some time. I also do believe that policy changes at the national level as well as potentially at the state level are going to be needed. And just to put this into context, and I think maybe this was the report that Jesse circulated, I was actually working in the United States Senate in the late 1990s, and I still remember to this day in and day out, insurance company lobbyists coming in to tell me that they were going to have to pull out of the Medicare Advantage program because they weren't making enough money. And in fact, between 1998 and 2002, close to 50% of Medicare Advantage plans canceled their contracts. And that was quite a crisis at the time, and lots of hand-wringing about it, and Congress responded. We obviously are in a different political dynamic right now, but there is a lot of conversation here inside the Beltway about what policy options do we have to try to address some of the instability that we're seeing. So I'll just briefly tick off a few things that are being floated here in DC and things that folks are kicking the tires on at the moment. Understanding, of course, that politics being what they are, we're not likely to see any immediate action. First and most important, I think there's strong consensus that we need to boost enrollment and make enrollment more stable. There are considerable headwinds, of course, that have dampened enrollment to date, not the least of which has been political opposition. And of course, we're seeing in states that actively undermines the law that's where we're seeing the greatest price hikes and the least amount of competition. But of course, constitutional challenges and the congressional refusals to adequately fund outreach and enrollment assistance also did not help. I don't think enrollment has to reach the Congressional Budget Office's estimates of 21 million people, but there have been analyses that suggest that the marketplaces can be sustainable and stable with those enrollment around 16 million. That's a Kaiser Family Foundation analysis. By the end of this year, nationally will be at just about over 10 million enrollees. So there's clearly still work to do to get to that 16 million figure. One of our presidential candidates has called for spending $500 million per year on outreach and enrollment assistance. It sounds like a lot of money, but considering that California alone is spending $100 million this year, $500 million nationally is maybe not that great, and I think it can also get us. It could be money well spent. The key is, targeting the eligible but uninsured, particularly during coverage transitions, coordinating strategies with your carriers, and providing that one-on-one assistance. None of which, of course, is really cheap. The other improvement that people are talking about, but comes with even more dollar zeros after it, is to address affordability, particularly for those above the 250% of the federal poverty line, where the subsidies really kind of fall off a cliff. For those folks, coverage, I think, for a lot of them is just simply not affordable. This, of course, is a very expensive option. I think under one proposal to improve the tax credit and cost-sharing support, estimated to cost an additional $221 billion over 10 years, which I can see a number of members of Congress kind of choking on that number. But I think we do need to figure out a way to help people get a better value for their premium dollar if we want them to get and stay enrolled, which, of course, in turn will make it a more viable market for carriers. Folks are also talking a little bit more about the public option. It's kind of resurfaced. In the wake of these plan exits, it seems to be coming up more and more in conversation. It was interesting, we talk about this in the paper, that when Congress, a Republican Congress, I would say, drafted the Medicare Part D program, they created a public fallback option that would be triggered only if there was limited competition in a county. So perhaps if it was only, you know, created in that circumstance, in other words, only as a fallback, maybe it would be more politically palatable, but we don't know. The other thing, of course, is the 3 R's, the risk adjustment, risk corridor, and reinsurance programs.
Brina?
Yes.
Sorry to interrupt. This is Dan Field. I just wanted to mention before you move on the public option, I just learned yesterday that our own Senator Merkley was going to be signing on to a resolution in the Senate around public option, and so he's been a particular proponent of that, and it's interesting you mentioned that because I just learned yesterday from his staff that he's pursuing that again with, as it was explained to me, the usual suspects, so Senator Warren from Massachusetts, Senator Sanders, and the others, but I think politically it's a long shot because the House is not going to support that. Maybe even it would not make it out of the Senate. But your point is well made, which is it's coming back now on the heels of the co-op experience 4 years later, and we're back to the public option as a potential solution. So thank you for raising that.
Yeah, and I completely agree. It's a political long shot. That said, you know, it was a Republican Congress that created the public fallback in the Part D program. And so there may be ways to relabel it or design it that could make it more palatable, particularly if it only is something that is triggered if you have no carrier that is willing to play in a market. But I completely agree. It would need to be some major rebranding to get it through. Same is true for the reinsurance. The Republicans or I guess I should say ACA opponents, have been very successful in labeling the reinsurance program as an insurance industry bailout. That said, I think there's a strong policy rationale for reviving that program for the Affordable Care Act. I think there's a strong argument that the individual market will always be somewhat sicker than the group market, and so given that selection dynamic, you know, I think there's an argument for it to get some subsidization through a permanent reinsurance program. In the shorter term, you know, the Obama administration has proposed some changes to try to make this market a more comfortable place for carriers. You know, for example, they are piloting a program to require documentation from people before they can take advantage of a special enrollment period. You know, my personal view on it is while I don't think people should be allowed to game the program, I think that's a relatively small problem. To me, the bigger problem is that only 15% of people who are eligible for a SEP even know about it. So in my view, instead of erecting barriers that only discourage healthy people from enrolling, carriers and the government alike should be aggressively finding and helping people during these coverage transitions. There's nothing about these special enrollment moments in your life, whether it's marriage or losing a job, that necessarily means that you are sicker than the general population. Other proposals being floated to Congress, often I will say by insurance industry interests, include allowing insurers to charge older people more in premiums. Currently, issuers are allowed to charge no more than 3 times the rate of a young person. I think the hope is that will bring more young people into the market. There are also proposals to reduce the grace period from 90 to 30 days. Again, I think in the hope of trying to you know, reduce the jumping in and jumping out of people who need healthcare services. Creating, again, revisiting the high-risk pools that existed in many states before the ACA, and allowing carriers to have more flexibility with their benefit design. All of those are things that are being floated on various sides of the political spectrum, and I'm be very happy to talk about any of these in more depth. But I know we have limited time, so I want to make sure we have opportunity for Q&A. So I'll just pause there and happy to take any questions you have.
Yeah, thank you so much, Sabrina. That's a great list, and it's going to generate a lot of discussion here. Let me just ask if there are any questions specifically about the issues that she mentioned, questions or comments, and realizing we're going to have a discussion in more detail about some of these ideas in the context of Oregon. And it was interesting, I was watching Laura didn't take a ton of notes because I know that these ideas are things that, you know, keep her up at night and thinking, and Barry and Pat as well. So
I will say that, Sabrina, this is Laura, I feel less alone.
Jesse.
Hi, Sabrina. It's great to hear from you, as always. This is Jesse O'Brien, and I was just wondering, I mean, it seems like a lot of those options that you mentioned were sort of framed in terms of what the federal government and Congress could do, and we can think about whether the federal government and Congress is ever going to be in a place to do any of those things. But what I would be curious to hear from you is whether you think states, or Oregon in particular, could do some version of some of those things, and which ones would be more effective than others, potentially, if an individual state tried to do them?
Yeah, sure. I mean, I think maybe what I can do is just talk to you about some things that we're hearing about in other states. You all are the best judge of what might work in Oregon, given your market and other dynamics. For example, as I'm sure you're aware, Alaska has enacted a state-level reinsurance program. From what I can tell, it seems to have had its desired effect. Of course, they only have one carrier, but the rates came down from, I think, the mid-20s in terms of percentage increase from the mid-20s to, I think, 9% increase. So seems to have been fairly effective, and we've talked now to, I would say, half a dozen states that are actively looking at a state-level reinsurance pool for those very high-cost enrollees. I think where you get the funding from is tricky. In the case of Alaska, it comes largely from group market carriers, but also stop-loss carriers and carriers, I think, of other non-traditional health policies. But how that works in a given state, I think, might vary just depending on your dynamics. Let's see. Other things that we have heard rumblings about. Some states are looking at Nevada, which has, as you may know, a tying provision. If you are a Medicaid MCO and you have a contract to serve the Medicaid program, you are required to participate in the marketplace. Other states, of course, have had tying provisions, based on, Massachusetts, I think, had a requirement if you had a certain market share in the small group market, you had to play in the individual market. I think other states have looked at leverage that they might have with their public employee purchasing agency. So again, different dynamics in different states, but looking at the leverage you have across different state programs with carriers might be one thing to look at. Let's see, what else? Oh, I don't know if this is appropriate to bring up, but I was struck by it, just given the politics in a state like Florida. In that state, they were looking at, I think it was the Aetna merger, and before they agreed to sign off on that merger, they required them to expand their presence on the Florida marketplace, which is run by the feds, but they had an interest in seeing more counties have more insurers. To be honest, I'm not sure what's happened with that in the wake of the Department of Justice decision to challenge that merger, but I guess the overarching question is, looking at at a state level, where are your areas of leverage and how can you exercise them, I think is the overarching point. And also that even in a state like Florida, where the politics has been largely negative towards the ACA, there are state level policymakers trying to figure out how to make it work for constituents.
Other questions, comments? I
hate to monopolize.
Oh, please keep going. And Sean had a question as well.
Oh, go for it. Okay. Sabrina, what do you think? What do you think the realm of the possible is in terms of a state pursuing a state-level public option or a state-level public option fallback along the lines of what you were talking about? Like
you know, I think the how is a really tricky question, right? I mean, in the case of the Medicare Part D program, which is the one I've looked at the most recently,
whoops. Did we lose you? Sabrina, we lost you if you're able to hear me. Just about to tell you how to build a public option. Always wanted to know.
We're waiting with bated breath.
While we wait, I would struggle with how you would have a single state assume the risk that would go with that versus having it nationalized by people who can print their own money.
Yeah. What I find interesting about the public option, and I know we won't get into a lot of detail, is based on our co-op experience, I think the public option is only going to be successful if it can do some things like rate setting and network setting, you know, similar to maybe what Medicaid and Medicare have done, and put some really tight parameters around. And then you're going to have the private marketplace screaming because they don't have the access to the same tools. And,
hello, I'm back.
Oh, good, Sabrina. We were just debating the merits of the public option, so go ahead.
Yeah, it's one of those ideas that sort of sounds really great in concept, and then when you start getting down to the nuts and bolts, you really very, very quickly run into challenges. But you know, when we looked at how it was set up for Medicare Part D, the government bore the risk, the insurance risk, and so that's, you know, the financing of that and how that works at a state level, I think, is a challenge. And then, of course, you have questions about how do you set up the networks and how the providers are compensated, and lots of really, really tricky questions.
Perfect. Yeah, I think that was Pat's point, that he used the phrase, the federal government can print money, which is helpful when you're running a public option. So,
exactly.
Also, because I mean, Sabrina brought up a lot of things that she's going to save me some time later, so we can have a good discussion. But
So Sean, question? And
one of the bigger things we can't address at the state level, and what hampers a lot of our other programs, is that there's no forthcoming federal action on the family glitch. Is that anything that would be on the table going forward in the next few years, or?
Yeah, I'm glad you mentioned that. Yes, there are a number of, I think, members of Congress, and also at least one of our presidential candidates has called for that to be fixed. So, you know, the problem is if Congress does it, it will be expensive, and so that it would be good to just have a new administration come in and have the IRS take another look at their decision on that one.
I have just a quick clarifying question.
Can you hear Cindy?
Yes, a quick clarifying question. With the increase that you see for 2017, I think you said it looks like it's going to be 26% to 30%. And you were wondering if it's a one-time. Didn't the previous year have a pretty significant increase as well? So it wouldn't be. So
I'm trying to remember. I mean, last year the analyses that I saw, again, you know, we're talking nationwide averages, which mask a lot of volatility. But I think last year it was something in the neighborhood of a 12%.
Yeah, it was quite a bit lower.
So, and don't quote me on that. I'd have to go back and look. I mean, you know, the other important thing to keep in mind, of course, is for anybody who's subsidized, you know, if with the subsidy that can really make sure that, you know, as long as you shop for a new plan, you're protected from that. But not everybody has a subsidy, of course.
And Cindy, this is Sabrina, this is Laura. When I get into the Oregon specifics, I'll talk about what happened in Oregon, because we actually, our state is a bit different from some of the other states in the sense that we did take some large rate action in 2016, whereas other states did not. And so I think that it partially is playing into why we're seeing lower increases in 2017 than some other states are on average, because we took some of that action to correct some underpricing a year ago. So, and we'll talk more about that when we get into the Oregon specifics later.
Okay. Well, and the reason I ask it is I come from the consumer side because I'm in the individual market, and my personal experience is very high increases. So I'm trying to reconcile what I'm hearing, and it's not resonating with experience. So,
well, what we're saying is you had a big increase last year and another one this year.
Yeah.
Right.
That's what we're saying.
That's what we're
yeah. Okay. I thought you said
other states had smaller average increases in 2016 than Oregon did.
The 12%.
Right.
Right. And then in 20 and you know, it's still, states are still in the process of making their decisions for 2017. But so, you know, I actually, when Sabrina was rattling off Minnesota, New Mexico, a few others that we've been observing, their range, you know, ranging into the 60 and 90%. Ours are like 9.8 to 29.3 on average. Some people will see higher increases depending on plans, where you live, you know, I mean, it really does depend. But we are not nearly at that extreme on average, but part of that probably has to do with the fact that we took action a year ago to correct some pervasive underpricing.
So, I do think there is a problem always dealing with averages. So, you know,
well, right.
or individuals.
Well, and that's the problem is, you know, you kind of need to find a way to articulate it, and then it's never going to be, everyone's not paying the same rate.
Yeah,
so
okay.
It's a challenge.
Yeah, thank you.
The problem is, Laura, you weren't very popular last year when you were doing that, and you probably won't get the credit this year for spreading the pain across the year.
My job is not to be popular.
But you did successfully help us avoid sort of what Sabrina just described as that 1 year spike. So let me bring this section to a close. And by the way, Sabrina, you're very welcome to stay on. We're going to take about a 5-minute break while people get food, but then Laura will launch in, and you're welcome to stay as long as you can. Let me also ask Maria, Joe, and then Ken, any questions from the phone? Ken is the CEO of Pacific Source Health Plans. I know he's got a lot of experience in the health insurance market. I'm wondering if he's still with us and has any thoughts.
I am, Dan, and I do have one question for Sabrina. And Sabrina, it has to do with risk adjustment. Any meaningful work going on to improve that system?
Yeah, well, I don't know about, you'll be the judge of whether it's meaningful or not. But my sense is the administration has heard the concerns from carriers about the methodology for risk adjustment. They've proposed some changes, unfortunately not probably to be implemented until 2018. But so one issue they're trying to address is they're trying to add in pharmacy claims into the assessment of your risk. That probably won't be effective until 2018. The other thing they're trying to address is the concern about partial year enrollees. Right now, the current formula doesn't, as I understand it, doesn't adequately account for partial year enrollees, so they're trying to make it more sensitive to account for those folks. And then they also are proposing, and this is all proposed, but they are proposing as I understand it, and here's where and maybe Laura, you can help me as an actuary, it's almost like a reinsurance component to the risk adjustment program. So for plans with very, very high cost enrollees, or I think it's over 2 million, that there would be sort of a spreading of the risk associated with those very high cost enrollees, and there would be greater compensation for plans that have them. That I may have just completely mangled what that section of the proposal does, but I think they are trying to respond. I guess the bottom line is they're trying to respond to carriers' concerns about some of the methodological issues.
Great, that's helpful. Thanks.
I don't know any more detail on the high risk piece to be able to kind of confirm or deny. So it sounded kind of in the vein of what I've heard so far in terms of trying to better address that risk.
Okay. Thank you, Ken. Pause for a minute. Any other questions? And again, Sabrina, I know you're on East Coast time, but you're welcome to stay with us as long as you can.
Thank you, and thank you for inviting me to join you. And good luck.
Thanks.
Okay, so what we'll do is it's 10 to 1. Let's take 10 minutes exactly. Everybody get some food. We'll come back and we'll ask Laura to dive in with us. It's just a few minutes after 1. I want to keep us on track. I think most of us are driving back today. Lucky few who aren't, we'll get you out early so you can enjoy the sun. The rest of us when I get home. But so we'll just kind of ease into this. Laura, I realized 10 minutes is not appropriate to give somebody
Thank you
time
for
to
giving me
eat.
slightly more than 10 minutes. So
Gave you a little bit more, but
well, that way you won't have to, see food coming out
yeah,
of my mouth.
that's good.
So
You're not on
actually
camera.
Probably worked out well. So do you want me to get started, or?
Yeah. So let me just what we'd like to do now is just sort of build on Professor Corlett's conversation. We have a good sense of the national landscape. There's not one state that has it figured out, and Oregon's just lagging behind. In fact, we're really in the thick of it with the other states. So I think the goal here is, and Barry helped me out, Jesse, I think the goal for our time now, Laura, is really to understand long-term challenges, both 2017 and beyond. Just framing this for us, remember we have our short-term and very clear deliverables around COFA, technology, BHP, open enrollment, et cetera. We've covered a lot of that today. But I think most of us also share a real interest in fact, a passion for creating a long-term sustainable marketplace. And so we're making room today for that discussion. And we'll really just sort of dive into the weeds here on what's happening currently, what we anticipate in 2017, and then start to build on the discussion with Professor Corlett around some potentially Oregon-specific options for stabilizing and growing the marketplace.
Sounds good. Well, Dan, thank you so much for having me, and Jesse, and really members of the advisory committee. I'm really excited to be here with you, and some of you I know well, and some I've probably encountered a few times, and some I've never met. So I'm happy to be here. Dan, we're finishing at 1:45 with this discussion. Is that? I just want to make sure.
I have until 4:15.
Well, we could probably take until like next week, but
yes. But we have some flexibility. But yes,
okay.
1:45.
I'll try to keep my comments brief because Sabrina hit on a lot of the same dynamics that we're seeing in Oregon, and I want to have time for lots of discussion and questions. And plus, I promised Jesse that he could pepper me with questions today. So, so what I thought I'd do is I'd start with a little bit of context and talk a little bit about what Oregon's market looks like now, maybe how that's different a little bit from what it looked like a couple of years ago, give you a bit of the setup of what's changed in the last 2 years, and then start to hit on what has really been happening in the last few months shaping the market dynamics going forward and where we go from here. So where I'll start is just with some context about the market that we have today, and I've got a couple of handouts in your packet that you might find interesting. I'm not going to walk through them in great detail, but starting with, it says, for discussion purposes only, health insurance enrollment by coverage type. So what I want to talk a little bit about, I know this group is focused on the marketplace and the population that is enrolling in what we're calling the non-group on exchange, but obviously that's part of a larger individual market that we're concerned about from a stability standpoint, since the rates are really looking at the entire individual market. And then I think it's also important to think about what does that look like relative to the entire state and really where everybody gets their health insurance. So if you look here, this all adds up to 100% of total enrollment in health insurance, but you've got the on-exchange individual market is a little over 3% of the total state. And you add in the off-exchange that you're directly enrolling with a carrier, with or without an agent, that takes us up to a total of 6% of the state is buying their insurance through the individual market. The other piece that I want to talk about next is the small group, which is another 4%. That takes us to about 10% of the state that is in individual or small employer coverage. It's employers that have fewer employees. And the reason that it's important to talk about that group is that is the group of people
where the rates that are charged for their health insurance are actually within our regulatory purview. So we actually review those rates. We have a team of actuaries that looks at them closely, and we are the ones who ultimately decide whether a rate gets approved or disapproved or modified to be accurate. So it's just kind of interesting to think about. It's really just 10% of the state that we have that sort of oversight over as DCBS.
Laura, if I can jump in.
Yep.
Maybe Mark and others can comment on this. So, you know, when you think about the state-regulated marketplace, and maybe you're going to get there, think of Medicaid, public employees. So I know some of the options we'll look at, and Professor Corlett mentioned the idea of tying participation in some programs to your participation in the others. So yes, it's 10%, but it's 10 plus 25 plus.
It's almost like 10 plus that 47.4 of some government involvement. So that's that last section of public. But you're right. I mean, so there's what falls under the purview of DCBS as the insurance regulator and the marketplace. And then there's what falls in the purview of state government, which would then fold in Medicaid. And I am blanking on what CAWEM means.
Assisted Alien Wave Emergency Care. It's the emergency only benefit.
Yeah, thank you. I was like, I knew I was going to totally butcher it. And is that, I can't remember, is that state or is that federal?
Oregon Health.
That's state. So you've got, you know, a little over another 26% there that falls in there. And then you've also got some pieces that are baked into other parts of group, which are PEB and OEB and other things that kind of fall within the purview of the state, you know, for some negotiating power. So there is a significant portion of our health insurance market that has either a state or federal oversight or negotiation or budget appropriation or something that kind of is focused on it. But I think it's important to keep that in context. So I want to just point that out in terms of, for the discussion about the individual market, that is a relatively small part, but an important part of the total picture. So I'm just going to flip through things pretty quickly, and certainly happy to answer questions, but I wanted to just set that up in context. So as we think about what has happened since 2014, that individual market piece, that 6%, has actually grown. It used to be less than 5%. The total of small group and individual has remained pretty steady around 10%, but we've seen small group shrink. We've seen individual grow. And, you know, there's a lot of different reasons why that might have occurred. I don't think we have a, you know, a clear picture on this is exactly what happened, but, you know, we've heard a lot of people talk about small employers have decided it's actually, you know, better for their employees to be able to go directly to the marketplace, maybe access tax credits, maybe cost share reduction to be able to get coverage. There also might be some factors. Our state legislature passed a law two sessions ago, or I think the last full session, that allowed smaller groups fewer barriers to self-insuring, and so we don't collect this grade of data about who's self-insuring and who's not, but there potentially could be some of that at play here as well. So I think that's just an interesting dynamic to think about. And I'm not going to go into all the great details on the back page, but you'll start to see also when we get into the individual market, what kind of coverage are people buying, and some things we've already talked about. There are actually still quite a few people buying bronze plans. So, you know, looking at 56% of people on the marketplace are, or sorry, this is, I always get tripped up. We put this in a weird place. It's actually 27% of the total marketplace is buying a bronze plan, and I think some questions about, are those people actually buying something that's of value, and is that driving some of the dynamics in terms of affordability and ability to use a plan. You've also got some interesting data about, you know, where are people concentrated. I think some obvious things in terms of the population centers and who's buying individual market coverage. Geographic rating area 1 is the Portland area, so not surprising that that's the largest, but we start to see a little bit about who's buying what where. And then also some dynamics about what we're seeing in terms of gender and age. And I'll come back to some of those demographics in a second. But as we start to think about what's changed in this market since 2014, the individual market began to grow. For the first time, we had guaranteed issue where no one could be turned down for coverage, and they could go pick any carrier they wanted, and that's a great thing. But it's also led to some really interesting dynamics as we've kind of seen this play out over the first couple of years.
And in that first year, we didn't have a lot of data. We didn't know who was going to enroll. We didn't know whether they had some pent-up demand for healthcare services, and if they did, how much. We didn't know what the dynamics would be in terms of would people choose based on price? Would they choose based on which doctor might be covered by which plan? We didn't know all of that, and we also didn't know if there would be enough incentives for people who felt they didn't need coverage to go and get coverage. So we saw that dynamic play out really in 2014 and 2015, where rates were being set and they were also being reviewed and approved by us with pretty limited data. And as a result, we had some of the most competitive rates in the country. We had at the time nearly a dozen carriers providing coverage in the individual and small group markets, and really competing with each other in many ways based on price. And I think in some ways that's really great for consumers in terms of carriers competing for their business. But the thing that we found when we got to the 2016 rate review process is we now had our first year of financial data for the carriers, which was their 2014 annual statements. Those come to us in early 2015, right around the time we're talking about 2016 rates. And really across the board in Oregon, insurance companies lost huge amounts of money, mostly driven by underpricing in the individual market. That, I think, based on things we talked about with Sabrina, was not unique to Oregon. But certainly we saw this as widespread and pretty much every carrier and across the board in the individual market. Some differences kind of here and there, but we saw that as really a pervasive theme. And we also realized that 2015 rates, which were already in effect at that point, and that ship had sailed a year prior, were likely to be just as underpriced, because we basically said, okay, well, we've got maybe a year of trend. We expect medical costs on average to increase a little bit year over year. Reinsurance, one of the federal programs that was in place to help stabilize the market, had less benefit in year 2 than in year 1, so we knew rates would increase a little bit, but we did not at the time know enough to know that we maybe hadn't collectively, regulators and the industry, hadn't understood this population well enough to be able to price for it. So in 2016, we not only corrected for underpricing that was occurring, but we were also concerned about some pretty fierce price competition that might be happening below cost. And we were also trying to figure out, how do you sustain a competitive market where it's not just about how much surplus you have and whether you can afford to compete below cost, and trying to really level that playing field. So that was a dynamic that we looked at in approving the rates that were charged for 2016. We also had yet another year of medical trend and the third year of the reinsurance program, which would again have less benefit than it had in even year 2. So that all played out, and I mentioned this in response to Cindy's question. We were a state that took what was certainly an unpopular, but we thought, and we still believe, a really necessary step of recognizing that the rates need to be adequate to cover costs. And we were concerned that if we continue to see competition below cost, we would see, frankly, some of the things that have actually come to pass. We'd see some carriers decide that they have to go out of business. So Health Republic, one of our 2 co-ops, made a choice that they had to, that they couldn't go forward into 2016. We had another carrier that this year, Oregon's Health Co-op, it was not really an ideal situation, and it happened mid-year. So some of the things that do happen when rates are not adequate came to pass, and we've also tried to make sure that we're preventing more of that from happening in the future. So 2016 put us in a place where rates are higher. We still knew that there would be maybe even a little bit more correction that happened to happen in 2017, since we moved carriers, what we thought, some of the way there to correct for underpricing, but that there would need to be another slight correction for 2017. And then we knew that reinsurance was going to go away completely. So if you fast forward to 2017, that happened, the 2017 rates, that process happened earlier this year. So from May through, I'd say, July, early August, we were going through that process. We had expected coming into it, we now had the 2015 financial results where we saw, yes, carriers were still losing money. It wasn't maybe, there was indications that some of the steps we took in 2016 were helping, but we still knew that there needed to be some more correction for 2017, and we also knew reinsurance was completely going away. The other question that we had was, okay, well, so all these factors might be pointing to the fact that rates have to go up a little bit, but are people, asking ourselves the questions, are people healthier because they've had access to coverage for a couple of years? What effect is that actually going to have on the cost to provide coverage for people? So we, and that's something that we even factored in when we looked at rates in 2016, but that was something that we wanted to make sure that we were being mindful of and not painting a picture of doom and gloom. But as the 2017 rate filings came in, we saw a couple of things happen. Some of them not surprising, some of them I think a little bit more surprising. When they came into us, we saw that largely the areas where we thought there was still some underpricing that needed to be corrected had really, the carriers had taken really steps to correct that in the proposals that they sent to us. So we didn't feel the need that we did in 2016 to say, we think that you're trying to compete below cost and we're going to need to push that up a bit. So that didn't happen to the same degree. One of the things that Sabrina talked about happening nationally played out in Oregon in a, I'd say, more expansive way than we expected, which was carriers making decisions either in whole or in part to limit exposure and leave parts or all of it. So we had already lost Health Republic at the end of the last year. That was a statewide carrier. LifeWise made an announcement that it was actually leaving Oregon entirely, not just the individual market, and they're going to be wrapping up at the end of 2016. We then had Providence and Moda and Pacific Source announced that they were shrinking their geographic footprint. And we saw that we had some areas where we were going to be down to 2 carriers in some places, and one of those carriers in all those counties where we had just 2, one of them was our other co-op that during the midst of that process we did have to close its doors. So we went through our rate review process. We knew that we needed to make sure that rates continue to be adequate, but also as we saw rates increasing again, we started to ask ourselves a different question. Are rate increases going to start to drive people who don't see the value proposition in insurance to not buy it? And is that going to actually destabilize the market in the future in a different way that we hadn't been planning for? We've been worried about getting people covered, getting them in, getting them access to services so they can get healthy. Could this undo some of that work? And
to address that point, actually, Laura, I've had people say it's going to cost me less to do the penalty than to pay these premiums, considerably, thousands and thousands less.
Right, and how do you help them see the value in insurance? Right.
That's really hard when they're just thinking about what their monthly expenses are.
Right. Some people don't have the luxury to consider the value of insurance, right? Because they have bills to pay, and if it stands in the way of them meeting other more pressing needs, then it doesn't even factor into the equation, right?
Well, they put their own value on it.
Well, right. Which is, or there's kind of a time, there's a little bit of, the immediate, I need to feed my family, I need to do all these other things, and right now I'm okay. Right.
Where one of the many areas where it would be nice if Congress could step back in and make some changes is on this issue, because Laura and Pat and Barry have heard me say this before, but there's a national observer and a columnist who so basically the tax credit's there, but it's really not enough to drive behavior, or the tax penalty, really not enough to drive behavior. And so we either need to get rid of it and not rely on the stick, or we need to turn it into a real stick. And it's kind of in a no man's land right now, to your exact point.
There's a question. You said that a lot of the carriers sort of self-corrected on those lines. So now why are they coming in with much higher rates? What's the...
Well, so there's part of the correcting of competing below cost would mean, okay, we need to do more than just account for the increase in the cost of providing care year over year, and kind of the trend of things cost more next year than they do this year. And we also had the reinsurance program that ended ends at the end of 2016. So it's basically a factor that was keeping rates a little bit lower that completely goes away. So that piece was in there, and so those factors all combined are really starting to come into play. I think you've also you've got some carriers. If you look at some of the filings that they all make provisions for either a profit margin if they're for profit, or a contribution to surplus. And in the first few years, where competition was really more price focused, we saw smaller margins or even no margins, and some of these carriers have depleted surplus, and whether it's intentional or not, I think, it depends a little bit on what each company's strategy was, and we may not know that. But there's now some carriers who've
said we need to rebuild. And I think that's one of the hard parts too, is that the nature of insurance is that you need to price enough to cover costs without being too high, without being too low, but you need to have a cushion for things not turning out as you expect. So those are the main dynamics that have been driving that. And when you see our range of being kind of 9 to almost 30%, it depends a lot on if you're talking about the carriers who had higher than average rates already versus those that were on the lower end. So that's kind of what's been driving that range.
And does it feel that it's balancing out more now, like the low going higher?
Yeah, we are seeing that there's, I think a bit of contraction in terms of the range of rates, but that's something that I think, and I'll talk a little bit about the dynamics going forward, but I think that is another question about market dynamics. If you see a new low-cost carrier every year, if people are picking based on price, right? And some people are sticking with it, especially if they might be subsidy eligible. The impact to them may not be as huge, and they might decide to stay because they're in the middle of treatment. They know their doctor's covered. They might make those kinds of decisions. Other people may be more price sensitive and say, I buy this because I need to be protected, and I want to make sure I'm, just getting, what I need for the lowest cost. But what might happen is we've seen major shifts in who's got market share from one year to the next to the next. And that presents other challenges in terms of, do carriers get to know the population that they're insuring and actually make good decisions about how they rate for that population in the future, about how they best address the medical needs of the population that they have, about long-term medical management so they can actually help these people get healthy, stay healthy. That kind of churn within the market, but between carriers, is kind of another challenge that we're going to have to figure out how to address and figure out whether there's something that needs to fundamentally change in terms of the forecasts, or are we getting to a place where we're kind of ironing out some of the kinks and we're going to have more and better and more stable data to be able to price more predictably. I think still remains to be seen. But I think 2017 is certainly, we know far more than we did a year ago, 2 years ago, but I still think there are some pieces in terms of that kind of price spread that's problematic.
So can you tell me what efforts might have been made with the carriers that, rather than coming to you with, this is what the increase we need to stay in business, what efforts have been made to have them turn to the providers and say, yes, healthcare costs go up, but why is this? What is there about your system that's making this so expensive? What is it about how you're providing care? Why is this procedure so much more expensive than it is in other parts of the world, in other parts of the Western world? What efforts are made in that?
So while we don't have a direct role in kind of that contracting process, we talk a lot with carriers about what they're doing in that realm. And what we're hearing really across the board is that carriers are, they have an interest in minimizing their costs too, right? If they can charge enough to cover their costs and be profitable, that's great for them. But we are hearing a lot more of trying to drive more, value-based payments, looking at kind of alternative ways to contain costs. In some ways, we think that some of those discussions might have driven some of what we saw happen in terms of decisions to leave certain parts of the state. It may not be the reason why every single carrier did it or why it happened in certain counties versus another, but we actually think that some of the negotiation to try to get to, okay, let's actually think about how we can best serve the needs of the population at the best price, the best quality, and that might have led to some strategic partnerships or some decisions to say, well, if we can't get to a place where I'm gonna actually make some business decisions that allow me to focus on areas where I can deliver kind of that value. There's still work to be done, but I think that has definitely been at play in terms of some of the decisions that we've shake out from a geographic standpoint, certainly.
If I could add, the other interesting thing is if you go back and look at the chart that had which segments of insurance have which populations, the market dynamic in areas where you've got a large monopoly provider, you're actually only talking to them about some small fraction of the market. And so if a carrier says, look, if you don't do me a better deal, I'm just gonna not offer policies here, the answer practically can be, okay, we don't care, because you're 10% of 6% of the business. And we're really wrestling with what's the dynamic, or what's the way to try to get at that dynamic, especially when we have absolutely no regulatory tools with respect to providers.
I'll tell you, in auto repair, the insurance company tells the body shop, this is how much a fender costs. You're not going to tell, and this is how much you're going to make, and I know how long it takes to put that fender on there and to paint it.
Right.
And we don't have that.
Right, right, because in this market, the body shop is able to say, oh, I'm not going to do the work then.
Yeah.
Ken, was that Ken that was trying to jump in?
Yeah, you know, I think obviously what happens at the local level is really important. I can report on our part that while we narrowed our markets, we focused in on markets where we could work really closely with the providers. The Central Oregon providers, as an example, really stepped up and are doing some really creative things with us, as is Legacy and some of their affiliated providers in Portland. I think one of the challenges here is that some of the big drivers are not controlled at the local level. So if you look at the individual market and you look at the cost of specialty drugs and you look at the cost of high-end treatments that are not provided locally and a whole variety of things, they explain a lot of the variance. And that's where we have a real tough place getting to a solution. If those things are going up by these incredible percentages each year, and we have a population that has a real high usage of those particular kinds of drugs or services, we've got a problem that it's hard to get your arms around.
I just wanted to run through a couple of quick other items that we're seeing in terms of market dynamics, and then really start to talk, answer questions and talk about kind of where we go from here. Because I think we've hit on a lot of really interesting dynamics that are shaping where we are. I think maybe to close the loop on what happened with 2017 rates, we were successful in working with carriers to come back into large parts of the state. In many cases, and not all, but it did lead us to a place where we've got several statewide carriers for 2017. But I think it kind of leaves us at a place where we need to figure out how we're going to address some of these underlying market stability problems in the long term to make sure that we don't just relive this experience a year from now. But it did mean that when we did convince some of those carriers to agree to come back in, it did come at a cost too, because as we've talked about some of the things that are of concern to carriers in terms of making this a viable business decision, which they're businesses, and that's something that they need to consider. But one of the things that I kind of alluded to, but is actually a really big factor here, is the guaranteed issue part of the ACA. That means no one can be denied for coverage is a wonderful thing, and it is one of it is really just fundamentally changed our health market in many positive ways. One of the challenges, though, is that if you couple that with some of the things we talked about are you the lowest rate in a geography, and maybe you didn't intend to be that much lower, or you didn't realize how much price might be factoring into someone's decision making, there's no lever for an insurance company to manage exposure, to say, I can either operationally only handle this many people, or financially, before I kind of start to feel a little bit stressed, kind of handle this many people. And that's been one of the challenges in terms of how do you control growth in a way that, and I think about this kind of with my regulatory view of the ultimate consumer protection is making sure an insurance company is there to pay your claims. How do you make sure that an insurer can effectively manage its risk in this environment? And so that's one of the areas that we're going to need to kind of continue to think about. You need to make sure you're delivering on all of the consumer protections, and that people are getting what they need, they're getting healthy, they're getting appropriate, timely access to care, but that at the end of the day we have kind of a robust, sustainable market that is there year over year, and there's not this kind of, well, is my carrier going to be the lowest price or the highest price next year, or are they going to decide they don't want to serve my county next year? Or are they going to cut down and go from 20 plans to 3 plans, and I'm going to have fewer choices? Or are they going to decide not to contract with my the doctor group that my provider is part of? So that all, I think, just plays into how do we make sure that we get all of the pieces out on the table and get to something that's sustainable. So I think I've really touched on along the ways a lot of the different things that I think Sabrina has mentioned have been happening nationally, but we need to figure out a way to make sure that people who are in this market stay in this market and understand the value of insurance when they're healthy as well as when they're not, that we've got tools for carriers to be able to
better forecast and better manage their risks so that they can be sustainable year over year. And, you know, I think we need to really get a handle on what are the market forces that are driving not just rates, but the underlying costs up, and how can we make sure that we're really, there's kind of appropriate pressure on those costs to keep it affordable and keep it really in line with the value that it's delivering. And these are all like really challenging problems to solve, but it's not kind of any one thing. And maybe just to close, Sabrina listed off a lot of different ideas that are on the table at the federal level, and right now we're working on our 2017 legislative agenda, and we have a placeholder concept that, you know, I've been kind of joking around internally saying it's the fix the individual market concept, which is basically what it is. Right now there's nothing in it that would tell you what the fix is, because we're still trying to figure out what's the best way forward. A lot of the things that Sabrina talked about, maybe all of the things, have been things we've talked about internally. And thinking through, so some of the questions Jesse was asking of, are some of these things, you know, are they issues we can tackle at the state level? Are there variations of this that might help us address the problems that we're seeing here? And really wanting to be thoughtful about ways we can be proactive and not necessarily wait for something to happen at the national level, or can we kind of pilot some things here that might help us inform the national conversation too? So with that, and Pat, I don't think there's anything else you wanted to add before we kind of just take
one quick concept, and that's, I think we're becoming acutely aware of, tempting as some ideas sound, kind of the law of unintended consequences. Not wanting to go do something that we think will make things better, that it turns out results in carriers pulling out. Because we still think having a vigorous competitive market is one of the most important things to achieve, and so that kind of takes up what is already a narrow path and makes it a little bit windy and twisty and difficult to figure out exactly where it lies.
It's challenging.
What is Oregon's uninsurance rate current?
There's new data on that. 9%.
I was kind of looking, scanning.
At 9% or 5%, depending on how you measure.
And I saw that Massachusetts is 3.2%. And so, I mean, that can be a goal, but we can also look at what's Massachusetts, another state, you know, not relying on the federal. What have they done?
Well, they've had universal issue for several years longer.
Yeah, that's.
And I think they've also had some more consolidation of some of their markets. I think their individual and small group markets, I think, are tied to a degree.
They also have more generous subsidies because they have a state subsidy that wraps around the federal subsidy. Because the ACA was actually a step backwards for Massachusetts in terms of the subsidy, so they had to create a state program to wrap around it.
I also think that Massachusetts has, I think that they have a little bit more rate compression, if I remember correctly, where I think there's less variability in the rates that you pay based on age, which, you know, probably swings both ways in some ways, but that's been kind of in place for longer, I think, coupled with some subsidies.
Jesse and I participated in that conversation with others around the table with leadership of the Health Policy Board and representing this group. So we were there on your behalf. And I mention that because I think the idea was to think about the state of Oregon in its entirety, not in terms of the market segments. And that was, you know, to my question earlier. So there's great work going on with the Oregon Health Policy Board. Many of us are aware of. There's great work going on with PEB and OEB. Mark, we know there's great work going on with the CCOs, and that the percentage of Oregonians in Medicaid is now enormous. And so the question, and I think we're really in the early days of this, the question is, what do you do with that all together? Those programs are so fundamentally different. There's no question that Medicaid is just night and day from the exchange market. And yet, you know, they're all Oregonians. Many of them are low income. Many are public employees. And how do you use those tools together? And I'm not trying to drive us towards any specific solutions, but I would encourage us to think broadly. Yes, we may need to dive into some very specific technical solutions like reinsurance, but we'll, you know, I think a lot of us, as I'm looking around the table at a lot of us were drawn by the opportunity, not just around the exchange or the marketplace, but around Oregon in general and the ability to get all Oregonians insured and to improve their health. And so keeping that broader picture in mind may lend us or lead us towards certain types of solutions where we say, geez, we know that people are, you know, churning between CCOs and the exchanges. There's something we can do there to stabilize both and to promote health in both of those markets, realizing those aren't really separate people. They're different people at different times, but they're really, in a sense, all the same kind of people.
So it's kind of this concept of, it's not, I mean, not just using I say not focusing on the issue of fixing the individual market. It's really kind of a more holistic, like, you know, we've got kind of a broader interconnected healthcare system. The individual market is a piece of that, and there are some things that are working really well, but there are some flaws that, you know, with any kind of new program would normally be kind of ironed out over a period of time with some fixes here and there, but, you know, because of the climate in Washington haven't happened quite as
well. And the challenge, Laura, I think that's well said, taking a holistic view. And the challenge we all have is, if you look at this, this is such a great chart. Who in their right mind would design any kind of market? And yet this is where we are. So that it calls to us to be creative across these silos and across these markets. And each of them, we have different tools. Clearly what Mark and Lynn Saxton can do, Medicaid is different than what Laura and Barry and Pat can do in the marketplace. So we've got to be creative, and hopefully the conversations we have with the Health Policy Board and the Health Authority and others will lead us down towards some more holistic solutions.
So I just have a comment in response to it, and I would agree that we are likely all looking at it holistically, but I think there is a tremendous difference when you look at the publicly financed healthcare options versus those that the individuals are choosing themselves, and you have all of those individual decisions, whereas in the public market, OEB or PEB or whatever is making a decision for its members, and they're kind of, somebody else is paying that bill. And the individual market, in my opinion, is very, very different, and huge risks related to it's of no value to me. If somebody's not paying for their insurance, it has tremendous value. But in the individual market, like my son, who said, the cost benefit is simply not there. Make healthcare affordable to me so I can go to the doctor. But I don't know why I need this insurance, this middle.
Our individual market is a little challenging, though, because it's actually a mix of both. Because we've got people who are getting sizable subsidies to be able to access coverage, and then those that are paying the entire freight themselves. And you have two kind of fundamentally different populations, likely, in terms of the value proposition calculation, right?
Right. I get that they're getting a subsidy. I get the subsidy aspect of it, but somebody's paying a check every month. I mean, out of their checkbook or whatever. That is a tremendous difference, I think, in coming from a perspective of once having health insurance provided by an employer that, okay, tell me what I need to check, and it gets paid, versus now you're in your own, choosing your own insurance. You have no idea. Transparency of cost is dismal, cost of care, and trying to determine those things. Pretty soon you throw up your hands and say the value's not there. What?
Yeah, but I think the problem is that what Laura's getting at is it's a lot easier to explain it if you're paying $70 a month than if you're paying $300 a month.
Well, we'll see. I mean, yes, it's explainable. The question is it valuable? I mean, that's the, if what we're seeing for 2 years, people have been required to have insurance, pay for their insurance. Well, if they're seeing, okay, I'm paying $70 a month, so $840, but I don't think I receive value. Am I Shauna's customer that said, forget it? I mean, I'm just not going to pay that anymore. And that, I think there's so much risk going forward because people have their own individual experiences and will say, I've invested this amount of money. What they told me in terms of the risk has not been there for me. I don't know.
And I just served on a retirement security task force where that act, I mean, there it's even, well, it's not as much per month, but it's even further distant to where you begin to even imagine that you're going to get any value out of it. And so the state has taken some steps and to address that, because what we all know is that when that time does come and nobody has accumulated anything, that and when you sit on that task force and you see those figures, what people don't have when they reach whatever age, and so it's because if we don't solve it, if we don't get a handle on what you're describing, people are going to lose confidence that the government can handle this problem, can deal with this problem, and they're going to strike out for themselves on whatever any oligarch, big mouth politician claims is going to solve the problem for them individually, and the heck with all my neighbors. And you're absolutely right.
I mean, part of this underlying problem is the cost of healthcare itself, right? I mean,
yes.
So if you're someone who's healthy and doesn't access healthcare on a regular basis, then you're not kind of confronted with that every day. And then you're really more in this frame of mind of, oh, I'll just take the risk that something terrible won't happen to me. And so people can think that way. If you're someone who knows that you are confronted with huge costs, then you're still having, you're making that value proposition calculation, but it still may feel like, okay, I'm going to spend, you know, $400 a month in premiums, and I'm going to hit my out-of-pocket max because I know I've got these conditions. And all of this is kind of part of the construct of the underlying cost of care. I mean, 90% of every premium dollar plus, in some cases in the last few years, is going to pay medical costs. Mm-hmm. And so the tough part is that, like, this is about spreading that risk. Right. And if you've got individuals who are basically saying, I'm going to just kind of hope that everything turns out and then either get burned or not, or, you know, wait until kind of healthcare is kind of provided to me by my employer in a way that I don't have to pay for it or whatever it is, they're not going to be able to kind of help step in and pool that risk. And then you couple that with where are kind of the right pressures in terms of what should we be paying for healthcare? What is truly the value of that? And that's, I think, a very large challenge to tackle.
We're nibbling around the edges when we're talking about
I mean,
what the cost of the insurance
we're talking about the financing of
carriers.
The financing of healthcare.
Right? So I wonder why health insurance doesn't mentally for consumers work like car insurance. I spend a lot of money on car insurance that I hope never to use in my entire life.
Or homeowners insurance.
Or homeowners insurance, same thing, right?
Well,
I have 3 youthful drivers, so I spend a lot more on my car insurance.
Those are, I think, so both of those are compulsory coverages in certain ways, right? So auto,
that's not why I buy it, though.
Well, but some people, I think, buy it because you're a responsible rule follower, you're a regulator, right? You know you're supposed to buy auto insurance. I actually think that a lot of people, so they got a car loan, they actually had to show they had auto insurance to get that loan. There's the fear of being pulled over by a cop who's going to see you're not insured. And it's different, I think, than right now where it's like, okay, well, I'll have to pay a little bit of my taxes. You're not getting in trouble. But it's really a financial decision rather than I'm actually going to get dinged. And then homeowners insurance, actually, you see similar dynamics where people who don't have mortgages actually have big lapse rates in terms of their homeowners insurance. So it's a really different dynamic where there's another mechanism where it's all required in some way, shape, or form, or a good idea in some way, shape, or form, but there's kind of a societal or a financial relationship that is forcing that coverage.
Plus, there's an expense piece of it. I mean, I pay $500 a year for auto insurance for, you know, 100 liability coverage, car cover, buy my new car or buy a new car for me if something happens. But I pay $500 a month for health insurance that provides nothing until I've spent $6,000 more than that. So, I mean, I think that's how people look at it.
Yeah, that's probably my perspective. I pay $500 a month.
Yeah, I was going to say you have like the opposite. Yeah, like
yeah, 20-year-old car ticket. So
no, I have 3 teenagers.
But so, you know, I've been paying auto insurance premiums for a long time, and I never get any, like, I'd say, tangible financial benefit out of my auto insurance because I don't get into many accidents. And so, but it is, I mean, I do think there's a different piece there. I don't know that it's I want to buy auto insurance because I know it's going to cost me a lot if I have to fix my car. That might be part of it for some people. My guess is those are probably the same kind of people who say, I'm going to buy health insurance so that it's there to protect me. But there's also there's, I think, a different attitude toward health insurance in the sense of, I think people think of it more like prepaid health services rather than insurance against a catastrophic event. Mm-hmm. And that is a fundamental difference. I mean, I buy homeowners insurance, I hope I never have to make a claim, right? I mean, seriously. you buy health insurance so that you can go to the doctor. It's a totally different mindset for people, right? I mean, and I think that's a big difference between health insurance and other types of insurance, where you buy health insurance so you can use it, and you buy the other coverages so you hope you never have to.
Well, it's hard to view it as asset protection if you don't have a lot of assets.
That too. And I think you'd probably run into, like, if you think about the younger population that might be struggling to find the value, those are probably the same kind of people who are not going to buy like renter's insurance. And I mean, there's just a different mindset. And I think it's about kind of risk across kind of like a long time period, and figuring out, like, you know, how to think about that in 12-month increments. And, you know, okay, well, I think I'm feeling all right now, so I'm not going to buy health insurance for now until I think I need it. Instead of thinking about the fact that something terrible could happen and it actually could have long-term consequences for you.
I would say just the time frame. I've had clients who are opposed to having to purchase health insurance say, I remember when car insurance was made mandatory. I don't remember that. My knowledge doesn't go back that far, and saying 20, 30 years ago, I'm sure there are a lot of people frustrated with it, and it wasn't normal I have to have car insurance. Now it is. So because that decision was made 30 years ago, it's not, you don't think like, well, I'm not going to buy it. So I'm sure fast forward 20 years, if things continue the way they have, health insurance also won't be weird. That's just what I do. I buy health insurance. You know, I buy car insurance. So we're just in the beginning of the wave.
It has to be affordable. It has to be affordable and viewed as a public safety. Car insurance was public. There were too many people getting into accidents who didn't have insurance and affected somebody's health.
Right.
So with health insurance, I'm just wondering, you know, you talked a lot about sustainability of the insurers staying in the market. It's the sustainability of consumers staying in the market that I think we approach, and it just seems public option to me, but because I don't know how you get your hands around it.
Well, I mean, I think they're intertwined, and I think I want to be clear that I'm not worried about, I am worried about consumers staying in the market, but I'm also worried about insurers wanting to stay in to provide coverage so people can buy in the market. And that's kind of the consumer protection piece of that, right?
Right. And I understand that, but if it's viewed as unaffordable or not value related use.
And that's where the cost of care becomes the real big thing, is that I mean, insurance dollars are largely going to pay medical costs. And so how do we get a handle on the cost?
I want to keep going with some questions. Jesse?
So I'm going to try to limit my questions. I have a large number in my head, but I feel like the biggest picture question I have about this is that it seems like there are a number of things that Oregon could do to stabilize the market in the short or medium term, including, you know, maybe a reinsurance concept, maybe something that ties different segments of the market together in some way. That there are a number of, I mean, the details are complicated and it might be politically difficult, but it's fairly easy conceptually to see how you could stabilize the market using some of those mechanisms. But those mechanisms wouldn't really resolve the underlying structural problems, which have to do with cost of care. And I mean, one of the things that I think just jumps out from the map of where the insurance companies were planning to pull out of is, you know, the way the broader healthcare market in those communities works. I mean, a lot of them are communities where there are very few provider options. There might be one large consolidated hospital system, or it might just be a frontier county where there just aren't a lot of providers or whatever. But there are places where insurance companies don't have mechanisms to contain their exposure to the cost of care. And as Pat was saying earlier, you just don't have any regulatory leverage over those relationships. Is there any thought that we need to go in the direction of figuring out some sort of solution to that problem? I'm not suggesting setting up a whole new regulatory apparatus, but like at least acknowledging that that's one of the main drivers of the problem and figuring out what we could do to start moving things in the right direction.
So, when I talked about our, fix the individual market effort, I mean, all of these things that we talked about, sorry, I'm referring to the list of things that Sabrina mentioned. I'm like, oh yeah, we thought about that too, that are more focused on fixing the insurance side of the problem. How do you finance it? I mean, we're talking about those, but we are also, we basically said every idea is on the table, and we are trying to figure out, is there something that we don't have, either we specifically as DCBS or the state, and maybe it doesn't make sense with us. Is there a tool or a set of tools that we don't have that we think we need that can help address that? Because that, I'm one of the first people to say, and you probably know this from years of working with us too, is that there are things we can do to fix the insurance side, but insurance is about financing this cost, and we need to kind of get a handle on how to fix the underlying structure. And I think there are other pieces in terms of, figuring out how to use benefits. If you want to drive incentives to people to kind of go toward value care, it's more than just having the insurers make good deals with hospitals. I mean, there has to be a way for the consumer to understand how to be a good consumer, which is really challenging.
So really, OHA setting healthcare prices would be extremely helpful.
There you go.
So let me actually, Pat, I think that's a great observation. I was going to actually go there and say, what's attractive about the public option isn't the idea that the government is running it. What's attractive about it is what that means for the market. It means that the government is going to set those prices. Medicare and Medicaid, you have fee schedules, you have rate setting essentially, you have lots of other parameters around network adequacy, et cetera. So my challenge to those of you who are passionate about the public option is, rather than just landing on the public option as the model, look at those underlying tools and see how we could bring some of those to the existing marketplace. Short of a full-blown public option and asking the government to come into the market, how do we give the existing market some of those tools that have worked in Medicare and Medicaid? And I think there are ways to do that, short of what we think of as creating a whole new public option.
So there has been proposed the idea of creating some sort of rate review program for hospitals or health systems, which I think would be, like I was saying earlier, creating a whole new giant regulatory apparatus, which we might or might not want to do. But I mean, there are states that do things like that already. The primary example being Maryland, which has what's called an all-payer rate setting system, where there's a board that sets rates for all payers in the state for hospitals. I think they might be expanding it beyond hospitals, but like those are sorry, my thought is half formed here. It seems to me that those are the kinds of solutions that are commensurate with the size of the problem, but that they're also really big, difficult ideas. And I don't know that there's the political will to even have those conversations. So I guess that's what I'm asking.
I think one of the things we're looking at, though, is are there short-term solutions or short-term steps that help build us towards the long-term solution? And I mean, I think we obviously need to be thinking about, I mean, the way I look at it is you don't want to let a political challenge of kind of getting something through stop you from thinking about a really good idea. I think you need to be aware of them so you know what questions you're going to get asked and what information you need to be able to prepare to kind of convince that you need to take a look at something. Or are there baby steps you can take along the way to kind of get you, poised to take that bigger action? So we're really thinking about it in that context of not just saying, well, we're probably not going to get everyone to agree to that, so let's just scrap it. But I think some of the ideas, I mean, I just think about what you're saying and what Dan was saying. I mean, I come, probably have to stop saying this soon, but I come from a non-health perspective, and I always think about what other insurance markets have been in crisis and what solutions have been used in those markets in crisis. And I mean, a lot of the things that happened in Medicare also happened in like workers' compensation, for example, which is where my background is. And so there's a lot of parallels here in terms of, fee schedules and how do you look at rates and how do you look at kind of making sure, I mean, we are a state that basically had kind of a public option workers' comp system where a lot of other states had that too. And so, I mean, there's a lot of parallels in a lot of ways where you can learn from things that have worked or not worked so well and, try not to recreate the wheel, but also kind of think big and figure out how to take steps toward that.
Sean's been trying to jump
in. I just feel like, at least on the price control issues, that a lot of those are too far removed for, especially a small state like Oregon, to really have enough of a sway with, because a lot of them the prices aren't necessarily set at the provider point. There's also input prices from drug companies, medical supplies, other things like that. They're now starting to assume that everyone's insured, because we've reached a point at which in the United States most people, 90% or so, have insurance, and they can now start to increase their prices to allow insurance to absorb the rest of that and assume that it's just going to get covered. It's not actually going to get felt by the consumer. So you're starting to see some issues because we have such a high insurance rate, which lets these input prices increase out of control. But I don't know if we really have the market share to tackle that as a state and say those input prices are driving a lot of the passed on to hospitals. It's not just them.
There's probably some things between, and I don't want to get too far out over my skis, but I mean that might be some areas where as a state you're looking at more than just the commercial markets we regulate, but are there kind of some things we need to be doing around all of the public, areas where there's public input or public involvement? And then I think there's also, we work closely with our colleagues around the country too. I mean, and figuring out, are there ways we can attack some of those problems more collectively at a national level, which I mean is more challenging, but I think that there could be something to be said for a group of states that can demonstrate certain things working in certain areas and kind of being a model. But I mean, you're right. I mean, there are certainly things that are not as easily within our control, even if, beyond being politically difficult. Like, can we actually influence them?
Laura, I'm going to ask you to close in a minute, but I want to go to the people on the phone and just give a minute to see if anybody on the phone has a question. And then, Laura, what I'd ask you to do is any closing messages around what we expect in 2017, and then I don't want to scare you, but before you know it, we're going to be into 2018 rate review. And
it's always rate review season.
It's always rate review, and then do you have any predictions for that? But anybody on the phone want to jump?
I want to hear this.
Yeah. I think I have a meeting.
It is right around the corner. Okay, so 2017.
Hey, Dan.
Yes, Ken, go ahead.
Maybe just a couple of quick thoughts as I was listening to all the discussion. One is I think I would be careful about assuming that all of the decisions to withdraw from Eastern and Central and Southern Oregon were tied because those were the worst performing counties. I think to some extent some of the companies that pulled back were looking to limit their exposure, and pulling out of the Portland market for most would be problematic. So it's where do we scale back? And I think it may not be a totally correct assumption to assume that the costs in those other counties were all way higher and the performance was way worse, and that's why they led that. They may have better relationships in some of those other places and not as much in those other counties, but that may not have been the driving force. Second is I like your idea, Dan, about thinking about it globally across market segments. I did agree with the points that were made that there are some unique aspects of the individual market that, the point was made that publicly financed healthcare doesn't have the same issues, and I would actually say group insurance in general. One of the reasons that it works is because people aren't making choices based on the coverage that they need. And one of the dynamics, I think there's some technical stuff going on in the individual market that's around some of the challenges with guaranteed issue, some of the issues around selection, some of the impact that low pricing or lower pricing, I guess, has in terms of impacting those things that presents some special problems. And then lastly, and I say this, I don't say this pessimistically, but I think it's really important that we not get, that we realize that there's still a ton we don't understand. And I think one of the things that everybody's struggling with, from regulators to carriers to consumers, is how to make this market work. And there's still a lot of dynamics at play that we don't get. I mean, there are things that between selection and guaranteed issue and pricing that are impacting the experience that just is problematic and is not real clear. There's not an easy answer, I think, at this point on some of those things. So with that, I'll shut up.
No, great observations, and people were listening intently, so thank you for weighing in. Laura, closing thoughts? It's all going to be great next year. What,
sure. Well, I first
you left us with this. So
I know,
this
yeah.
is a little depressing, and I'm waving around Ken and others.
It's better than it started out as,
so
right?
So do you want to share what happened there, because there is
a
story behind the numbers.
I did a quick, I think I kind of addressed it in like 2 seconds earlier, and I should also point out that, Ken, your first point is well taken, and I concur. I think that is that there are a number of different reasons why carriers made those decisions initially, and I do agree that managing exposure is certainly among those factors. So I think it is important to recognize there are a lot of different moving pieces. So looking forward to 2017, I think as Dan was alluding to, our what 2016 looked like in terms of who's participating where versus 2017. Talked about this already a little bit. We've lost actually 3 carriers completely. So that's LifeWise, Oregon Health Co-op, and actually Trillium, which, I'm sorry, they weren't statewide, but 3 carriers that were offering in the individual market have completely left. And Trillium was only offering in 3 counties. No, 1, sorry, that's the only 1 county. I thought it was just 1. So they've left altogether. We then, we had Moda, Pacific Source, and Providence initially come in to reduce their footprint for 2017. We worked with those carriers to see if there was any ability to expand back out into parts of the state. Initially, we weren't successful in doing that, and then Regions and Bridgespan also announced that it was going to be reducing its geographic footprint. We then we have an appeal process that's relatively new in our review process, and we use that to work with Providence, Regions, Bridgespan, and also Atrio to expand back in the case of Providence, Regions, and Bridgespan, back to a statewide coverage, and Atrio expanded into part of Deschutes County through that process. And I mentioned before, this is really something that we've really looked at as trying to make sure we can continue to have options in 2017, have stability that will allow us to get through the next year while we're working on a longer-term solution. And so I think that's really critical that, and I probably said this before, but we don't want to actually get into 2018 and just see this all happen all over again. Right. There needs to be something on the horizon that's going to lead to stability, that's going to mean that the carriers make business decisions today in these markets. And that's really a critical piece.
And Laura, I also think that people want to have loyalty to a company. I've had people come in and say, I've been with Regions for 20 years, but I can't afford them anymore. Or Kaiser, for example, great loyalty for Kaiser, I hear all the time, but we're not in Kaiser County right now. Kaiser comes in, we're going to get a Kaiser plan. They want to be attached and not have to think about
it every year.
That's right.
Exactly. So I think it's important. It's like a decision people don't want to have to revisit if they're happy with what they have, happy, right? So I think in thinking about 2017, I think that's going to be one of the big pieces, is that we've taken some measures and worked closely with carriers to stabilize things for the time being, but we have a lot of work to do. And so I think between our placeholder legislative concept that we're still working on, and I'd say in the next month or so, we are going to be solidifying some ideas and starting to work with stakeholders, including you all and others, to say, okay, here's some ideas we're thinking about. What do you think? What are we missing? Are there kind of some unintended consequences we need to be worrying about, or did we actually come up with some good ideas? And I don't actually have the answer sitting in my back pocket here that I'm not sharing with you. We're still figuring out what are the ideas. Probably more than one is our guess. It's probably not one single thing that's going to fix it, but we're going to need to come into 2017 with probably a package of things that be a combination of long and short-term things to kind of help us get to stability or steps toward a longer-term solution. So I think you also asked me about 2018.
No, that's okay.
I think 2018 is going to be hopefully dependent on some fabulous solution we come up with. But I mean, I think one of the things that's going to be interesting for us is I did not talk about this. We've got the first 2 quarters of financial data for the insurance industry has come in. So we've seen what's happened year to date in 2016, and it's improved. Some carriers are making a profit. Some are coming closer to breaking even, and that's good news. I mean, I think that means that we're moving more.
And that's with last year's round of increases, not this year's round of increases.
Correct. And someone might ask, well, wait, why are you increasing rates again? Well, so remember, reinsurance went away. Medical costs do tend to increase year over year, and so we think 2017 is certainly poised to be better. But I think back to the couple of things around, well, if rates increase, does that start driving people to make decisions that take them out of the market? I mean, so I think that there's still some concern about destabilizing effects, and then will carriers still decide to serve that market for a variety of reasons? I mean, I think that's where we need to figure out a way to solve the underlying problem so that all of these kind of dynamics don't just create a repeat of this year or something worse.
Okay, so just a couple final comments. Okay. I think we have 3 people, and then we'll move on.
So I'm biting my tongue on a lot of comments and questions for the sake of time, but 2 process questions, one of which is, will it be possible for someone to come to our next meeting to present on what you come up with?
Barry, will you invite me to another meeting?
I'm not sure. I'm gonna give it some thought.
I can probably cover it if you're not allowed to come.
That's true.
How the evaluations are on this one.
Yeah, November 9th feels like the right time frame, absolutely.
Yeah, we certainly will. We'll be in a position to talk about what our proposals are. And then the second question is, this is looking forward to my nightmare season next year. The rate review season actually starts while the legislative session is still underway. But it seems like it would be fairly critical to have some legislation that could pass quickly.
We agree.
We've been talking about working with leadership or key committee chairs to have some bills that are available to gut and stuff with some ideas kind of on deck depending on what we see. To the question of what we expect to happen in 18, we don't know. You'd like to believe that now that all of the temporary stabilizers have in fact expired, and now that we think we've done what needed to be done to deal with underpricing, that what should be left is simply whatever the ordinary trend line is. But that assumes some things like this round of price increases didn't cause a bunch of healthy people to bail out of the market, so it gets a lot sicker, or that there's churn going on that we don't have data visibility into that causes this population to have a different risk profile even than we understand. And you're right, we won't know that or we won't know what the companies think is happening until we actually see the rates filed on May 1st, which is hopefully close to sunny day.
The one thing, realistic ideas, so let's hope that happens. So the other thing I might say, and my poor actuarial staff is going to kill me for saying this, but sometimes what we've done in the past is if we're working on an idea and we know that it may take a little while to actually get a decision, but we think we've got some good consensus, we'll actually be working alongside the carriers to say, here's kind of what the framework is. You need to build this into your rates, and if we have to adjust in the midst of rate review, we'll do that, and we'll do that in a way that's uniform. And so, the first time that we did reinsurance, actually, we were kind of building it as we were driving it, and that's the way we had to handle it. So
okay, Sean, and then Cindy. And
so Ken had mentioned some procedural issues with maintaining market stability, and you had mentioned the partial year re-enrollment. I was wondering, are you planning to direct the outreach and enrollment staff to spend some time messaging about identity verification and other documentation that you have to submit after the fact? Does about 1 in 12 people lost coverage due to that reason or something like that?
Oh, really? Go ahead.
It's you.
Sure. Are you asking if we're going to help kind of police special enrollment periods?
No. So if you submit your information to the marketplace, then you'd have to submit income documents or something like that. As many as 1 in 12 people, according to some Kaiser Family Foundation data, loses their coverage or their tax credit to that reason. And if you're one of the higher risk users, you're more likely to get that documentation in and get all your ducks in a line. So you're just losing a healthier subset of the population in that 1 in 12 people, which might be significantly affecting the pools.
So this is the data matching issues that we've been, it can't be one of many.
One component of this exact issue is just kind of how cumbersome it is to either upload your documentation to healthcare.gov or to have that information matched with your application. So I know that is, I believe that's part of outreach, is to remind people, at least part of what all of our outreach center folks do when they go and talk to communities. They explain that entire process, and so hopefully that helps people, but it is just a really cumbersome process.
And I'll be honest, and this is part of what Cindy and I talked about, just in terms of FFM customer service and complaint resolution and the timeliness of their work, a huge frustration for us, because we have one person whose almost full-time job is just kind of doing high-level constituent issues with the FFM. And we can get to a certain place in terms of helping the consumer, but oftentimes we push to a point and then we either aren't successful or we can't push anymore. Mm-hmm. And we've tried some other avenues of pushing to try to get more help at higher levels and have not been successful. So
that's interesting because as the agents, we have been complaining about the FFM since it started. And, you know, Cover Oregon we had our issues with, but certainly not like we've had with the FFM, because you can't get anything done. You can't seem to get
a high
level where it takes months and months. I've had appeals that have gone 6-7 months.
Oh, easily.
Actually, I think when you last met, I think, well, at one point I had told you guys that we were actually asking CMS for our own kind of liaison person, and they just, they absolutely came back with absolutely not. So the recent avenues we've tried to really break some barriers have not been successful. Doesn't mean we're going to quit trying. No.
Okay, Cindy, can you close us out on this topic?
And very quickly, just with respect to your fix, you know, your undefined fixes, just a question, any thoughts about more cost transparency of services? I've heard there's some legislation.
That's on the brainstorm list.
Okay.
Yeah.
And the metal level dispersion, so from bronze, silver, gold, claims made versus premiums paid, because if you're the younger millennial population says, I don't need health insurance, I'm going to do a catastrophic plan that they never use, are the claims made and premiums paid associated with that, or are those premiums being used to fund healthcare for
so in the rate review process, carriers have to justify the rate differences between bronze, silver, gold, and catastrophic, and they actually have to demonstrate data to show, you know, why the rates are different. And so there's that piece of it, and then there's also a calculator that they have to use that basically shows how the benefits that a plan pays out on average are kind of meeting the metal level. I mean, are you basically saying, are people just not filing claims for bronze because it's...
No, because people at the bronze level may be less apt to use their coverage because they have to pay for their health care up to the high deductible piece, are they less likely to use their insurance coverage? And that is, you know, if that can be brought down, maybe millennials who would choose that coverage would, and I tried to get that.
It's hard data to have, because you're talking about people who are not filing claims, so therefore the data wouldn't even be showing up for the insurance company.
No, but it's just claims made versus premium, and I tried to get that information from.
Like, what are the claims costs versus the premiums by metal level?
By metal level, and I was told that wasn't available. And
okay, we're talking about like loss ratios by metal level. Okay.
Yeah.
Okay.
Whatever.
So we do not have that level of data currently.
Yeah. But and I think that's unfortunate if you want to price a plan for millennials, or lower people who aren't going to spend as much.
What I'll have to go back and look and see if we have that level of detail in terms of justifying the rate differences between the coverages. Okay. So I will have to take a look at that.
You must have the loss ratio by metal level.
I don't know offhand if I do, but I'll ask.
I was told it was just not available.
I'll find out.
And then the last thing is uninsured medical care. I mean, just because you don't have insurance doesn't mean you don't have medical care. And you know, I was faced with a situation that I can talk about privately, but it struck me that if I didn't have insurance, I'd pay the same for my medical care. And how often? So if that's one of the factors that people are saying, well, it's just insurance I'm not buying. I can still go to the doctor. I can get.
Well, yeah, this is that whole idea of, are you buying insurance to protect against a catastrophic event, or are you buying insurance to help you get access to care? Right, and for a lot of people, they view it as, I buy this so that I can have a copay that's relatively low, so I can go, if they don't think they have access to a place where they can afford to pay out of pocket for the same rate that they would pay with insurance, right?
Right. I mean that. Okay. That I was just trying to make. I think you had made just a comment about people buy insurance so they can go to the, or the need is they buy insurance so they can go to the doctor. And I don't think that's true if they find out, no, I can go to the doctor. I don't need to pay my.
Well, I mean, so you've got differences in terms of if you have insurance, you might actually pay a lower rate because there's been something negotiated by your insurer. If you self-pay, they may charge you more.
Well, maybe, and I thought that was true, but I just found out that.
And the hospitals have got pretty adept at signing you up for insurance if you show up without insurance.
Well, I'm sure the hospitals are a whole different story.
No, I think it depends on the provider, certainly. And
hospitals have a lot of restrictions around how they set charges for uninsured, but you're talking like if you go into a certain urgent care center or a physician office.
Or, yeah, my doctor.
Well, and we've had some, you know, honestly, we heard about some providers telling Oregon's Health Co-op customers, you know what, don't even bother coming to your appointment in the next 2 weeks unless you can demonstrate that you can pay, because, and so there is, I think, a little bit of this difference of insurance is often viewed as the ticket to getting coverage or getting access to care.
Right, but in that case, the provider was just worried about payment. Right, I mean, really.
Well, I can see that there are probably some people
Breaking
for
the
whom
law.
pay is an option, but I think a lot of people, it may not be.
So Cindy, I don't want to cut you off,
Yeah,
but I want
no,
to,
that's fine.
and I just want to, as a transition point, I want to thank Laura, and really starting with Pat and the entire team. We heard Sabrina mention that there have been some states that have actively undermined their exchange. Dawn reminded us of a horrible story in Wisconsin where that actively undermining was taking place. And I just want to pause for a moment and say we're so fortunate to be in a state where not only are you doing what's required by law, Pat and team, but you're actually convening groups, having conversations, working with legislators, spending time with us in an effort to really build and maintain a sustainable insurance market in the marketplace, out of the marketplace. We're so lucky that we don't live in Wisconsin on this issue. I'm sure summers are nice there, but mosquitoes, but you know, very unfortunate. And there's a number of states where these conversations are not occurring. So I just want to thank you all. You're going sort of above and beyond the call of duty on this, and it's we think it'll pay off, and we think 2018 will be a great year, Laura. We're going to help you get there. Indeed. So with that, I'm going to rely on people to take their own stretch break, but let's power through. Our guest has been so great, Hannah, about sticking around, but I'm going to let Dawn introduce her and talk about our next topic.
Yeah, so Hannah is from the Oregon Foundation for Reproductive Health, and we've had conversations about a special enrollment period for pregnant women, because that's currently not offered. So what I'm going to do is I will give a very brief overview of the special enrollment process in general and what 2 other states have done, the only 2 other states who have implemented a special enrollment period, and then I will hand it straight off to her to actually discuss why the utility around a pregnancy special enrollment period and what that might actually look like. And then the last piece that I will talk about is that I hate being this Debbie Downer always is the federal technology limitation. I sound like a broken record about that. So really briefly, the typical consumer in Oregon enrolls through open enrollment period between November 1st and January 31st, and then they have their coverage for the next year from January 1st through the end of the next year. Also year-round, what is available for people with certain qualifying life events, certain triggering events like a loss of minimum essential coverage, is to enroll through a special enrollment period. And the one thing that I want to make sure that I make clear is that that could be available to you during open enrollment. It's not outside of open enrollment. You might lose your coverage in the middle of November, and so although you've enrolled in the open enrollment to start coverage on January 1st, you could also need coverage for the month of December. So you are eligible for a special enrollment period, you enroll in November, and you have coverage for that month of December. So these qualifying life events happen all the time. These special enrollment periods are available to consumers everywhere. The main one is this loss of minimum essential coverage. If you add people to your household, meaning you have a child or you adopt a child, there are some triggering events for when you either increase your income or decrease your income and you're newly eligible for premium tax credits or cost sharing reductions. So there's several different triggering events that you can be able to enroll through these special enrollment periods. That's what I'll say about that, and I'm happy to answer more questions there. Vermont and New York are the 2 states who have just this year passed into law special enrollment periods for pregnant women. I talked to both of their exchanges, and neither of them are ready to provide any data on this, and they haven't started collecting it. So Vermont just started their pregnancy SEP, became available July 1st, and New York is a little bit harder to track down. They're really trying to keep this one a little bit under the radar. They have a much lower utilization of special enrollment period because they have the basic health program, which is a continuous eligibility. So just in general, they're really hard. New York's a very hard comparison to make to Oregon. So we don't have any data yet. There was legislation in California this year in California to have a pregnancy special enrollment period there. And so this leads me into the last part of what I will talk about, which is those are all state-based marketplaces with their own technologies, and so they're able to implement this type of special enrollment period. And our struggle is that to qualify or to have any sort of federal subsidy, you have to enroll and go through the healthcare.gov eligibility system. So although it is always possible for Oregon to make some sort of workaround and use technology, that's not accessing necessarily the federal subsidy, which is part of the point of enrolling on healthcare.gov. So that's where kind of this struggle comes with how can we innovate and do something on our own, but we also need to be able to have access to these tax credits, which we can only access through healthcare.gov. And at this point, the feds have indicated that they're not opening special enrollment periods up anymore, or expanding them, I should say, to the qualifying life events. They're not expanding the reasons that you should be able to enroll in a special enrollment period. In fact, they're kind of going the opposite direction. They are really trying to constrict access, it seems, and limit access by requiring more documentation either upfront or at the tail end of a special enrollment period, which I'm happy to talk about after this or go into any more details in there. But without further ado, I want Hannah to be able to talk through the pregnancy.
I'm actually going to move over there.
Yeah, please. Great idea.
I was like, I can't adjust enough. So thank
Victor, will we still pick her up on a microphone?
I could, you want to sit here?
No, I want people to be able to see her.
Well, I know, I'm just thinking, well,
or can that one stretch? Anyway, and people on the phone, I hope you can hear me. I'll speak up.
Yeah, just slide it. Perfect. No, that'll work. That'll work. Go ahead.
But,
Lisa, go ahead. I think
just a little background on myself within healthcare transformation. So I've been in this role for 4 years, and we started working with, actually I started when Recover Oregon was just getting in place. We did a lot of enrollment, outreach, education for that piece. And then we've been involved in some different pieces with birth control, mandated coverage. I'm also on the basic health plan steering committee. I was last round. I am this round. And anything else. It's like you guys are on a lot of panels together. So, but I appreciate taking the time. There are the special enrollment period for pregnancy, just like a lot of the other things, has been it's already been 2 years that we've actually been working on this, and in that time, a lot of different moving parts have happened. Again, it's an issue that relies on some federal and some state, and depending on who's willing to do what, we can look at. It can look differently. So the Oregon Foundation for Reproductive Health in the beginning of 2015 wrote testimony to HHS asking them federally to change and include pregnancy as a special enrollment period. When they came out with the reasoning that they were not, but each state could, we started forming a coalition of groups that actually wanted us to see this in Oregon. So we have right now 7 organizations that are signed on. After that, we actually met with Pat and Laura to kind of say, this is what we're thinking, how do you think we should proceed? And because DCBS and the marketplace have been so open to advocates, they said we're open to listening to this more. And we actually presented at the Rulemaking Advisory Council at the end of 2015 into 2016 with this concept. That group looks a little different than this in that it does have insurers and insurance companies there, so we got to see.
We do too, just fewer of them.
We do. So we got to see right up front the different the pieces that were really contentious to some folks about whether this should happen or not, and that gave us kind of this real understanding of the values are there, but what it looks like and how we actually get coverage for people when they become pregnant. We want that, but how we actually get there might be different. Why we're pursuing a special enrollment period is because of this. It is an option. I mean, we believe in innovation, but we also see what there is to work with. So I'll just go through this handout because it helps me think about the different ways that we talk about it. So again, the special enrollment period right now, if you give birth or adopt a child, at that point you are eligible for a special enrollment period. And kind of just basic logic is that if someone wants to, if someone becomes pregnant, then we actually want them to be able to have the insurance coverage during their full pregnancy, not just after they give birth. The implications of lack of access to health care insurance during pregnancy. There's a lot of research out there about why we want to get people covered and why we think that making sure that people have the ability to get insurance when they find out they're pregnant and being able to access prenatal care services, to have a healthy delivery, to have a healthy newborn, etc., are all there. There's the cost outcomes, there's the health outcomes. One of the things that is alarming still is that the U.S. actually has the highest, sorry, the words are escaping me. Where is it? But the pregnancy mortality, so of all developed nations.
Infant mortality.
No, women die while they give birth.
Specifically during birth, not necessarily during pregnancy?
Yes.
Okay.
And it is, and since I've been alive, it's actually doubled. So our rates on that are actually going up. So just that is alarming in terms of we have access to really great health care coverage. We have all these different things that we know, but we still continue to have not only an increase in that, but we also have increase in health disparities. So this is also an issue even in Oregon by income and by cultural or racial categories. We're seeing different health outcomes within pregnancy. So what we really need to do is stop creating barriers for women to get coverage during this important time. And this is, again, a really small piece. We're kind of used to working on issues that affect large groups, and particularly we're advocates and sometimes we work with low-income women, but we really are talking about the marketplace being able to actually get on par with Oregon Medicaid right now. So right now, women who do qualify for Medicaid can enroll year-round. They have great benefits. We actually also did prenatal care for all last year, so that even women who cannot be on Medicaid for full benefits do get Medicaid benefits for prenatal care. So Oregon has made this commitment to improving maternal and child health outcomes. Even within our CCO metrics, they have some around early prenatal access and reducing elective inductions before 39 weeks. So we're asking the marketplace to actually balance that so that consumers who want to purchase their health insurance will be able to do that at the same, have the same opportunities to do that women who would go into Medicaid could do. So we have all that going.
Hannah, did you actually, I can't remember when I read it, but was there actually the number of women this impacts each year in that?
So
the number?
One of the things that's hard to tell is, again, getting the real information about
we're not
this.
insured, so we're not tracking them.
Exactly.
Okay.
So what we can tell is that because we do have a really low uninsured rate in Oregon, that alone versus other states will say that this is going to be pretty low. What we do know is that we could find people who enrolled in the special enrollment period at the beginning of last year. They lumped them together with, it says like all others, and it includes folks who did use this option for birth, and that was 1,800 people, but that was multiple options. So if we think just a section of that, the women who give birth, if they actually tried to enroll when they actually became pregnant, it would be below that. So we also had two professors of public administration who do health policy at PSU write some testimony saying that they thought that this would have a minimal impact on marketplaces, as other economic advisors have said, because it should be a pretty small number. So I think they were thinking it's almost like the COFA, where we don't really know until it's out there, but between 500 and maybe 1,000 women per year. And they had an actual interesting argument as well in terms of women when they do become pregnant, wanting to get insurance at that time to have early prenatal care or early pregnancy related care. So not all pregnancies end in live birth, so there's other miscarriage and abortion care that need to happen as well, and people use their insurance for that. But that women will still have to wait until open enrollment. And so they will still be able to sign up during open enrollment, but might just be further along in their pregnancy. And their logic was that actually signing them up earlier than making them wait till an open enrollment would be beneficial. So I think, again, it kind of, we came to think about it from a policy perspective and see what we can do within the bounds that we can do this. HHS has not said that they disagree with the actual policy of it. Their only stopping point has been the technology piece. And that's the same sense that I get actually here in Oregon, is that it sounds like it could be something that would help move us to have better health outcomes. It actually would help us with our enrollment numbers, but our technology piece of actually how we do it or not is kind of the sticking point for us. So again, I'm not an extreme advocate for this to have to be through a special enrollment period, but I actually think that this group has some good, they've seen some innovation already about how we can help ensure that populations who need coverage to remove barriers from them getting it when they need it. So whether it is a special enrollment period or depending on what it looks like within 1 or 2 years here in Oregon, how we can make sure that consumers can get on that marketplace when they need it.
And Dawn, what CMS has told us is that we simply, it's not that they're against us having a special enrollment period, because they simply can't accommodate special enrollment periods that are outside of what they already do for SBM, FPs, right? So it really is just a technology issue.
Yes, it's not correct. There isn't an ACA provision that says that you can't do this. That's why other states are able to. It's just not one of the delineated reasons that the FFM can do it.
And this is a dumb question. I think Sean can probably answer it. But when a woman has a child, if she is uninsured before she gives birth, I know she's obviously able to enroll her child in insurance because that creates an SEP. Does it also create an SEP for her or just the child?
The entire family, and there's different rules between the Oregon Health Plan and the federal marketplace on this. Oregon Health Plan is going to let people enroll at any time. It's also going to count the pregnancy as a person, and then so it's going to be a 2-person family, and then the mother would qualify up to 185% of the percent of the poverty level for a 2-person family in that case. The federal marketplace is still only going to count her as a single person on the federal marketplace side, so she's going to be getting the tax credits and all that of a single person. So that whether the marketplace would then start counting the second person as a person in the family for the purpose of tax credits, that way the qualification limits are going to line up well with Oregon Health Plan, because Oregon Health Plan is going to be considering her 185% limit for 2 people, which means she's going to qualify up to a much higher level than she would on the marketplace side, and maybe get like less tax credits than she might otherwise deserve.
Just to give a little more detail.
But Sean, with the qualifying event, make her eligible. Isn't it the baby that's
shared by the family
eligible for coverage?
Yes, the entire family, everyone in the family, even if it's a spouse as well, every other children, everyone would share the same enrollment period in the family.
So one addition that I'll make is that this particular event, you also don't have to already be enrolled in a qualified health plan. So some triggering events, you have to already be enrolled through the marketplace, and that's the only way a special enrollment period is available to you. But in this situation, if you're just enrolled through direct enrollment with Kaiser, for example, but not through the marketplace, this triggers you to be able to use the healthcare.gov.
Ken, does that answer your question?
It does, thanks.
Shauna.
Well, to this point, I had 2 of them last week. 2 people that came in that were pregnant. One of them had a qualifying event because she had just moved into the area. Because of her income, in going through the marketplace, I assumed that she would be considered as a single. It didn't happen. She was considered a multi-family, 2 people, and it put her into the Oregon Health Plan. So that was a little bit of a surprise to me. So
That's because the Oregon Health Plan rules,
Yeah.
it has to defer to the Oregon Health Plan always. So the Oregon Health Plan's rules are going to count her as 2 people, in which case she's only going to qualify up to that point, which is about
my point is
$27,000 for a single.
Through the
first
federal
woman.
marketplace, they have the question that says, are you pregnant? We said, yes, she's pregnant. And then it came back with the assessment rather than getting a tax credit so that she was eligible for the Oregon Health Plan.
That's the correct
Doing
determination.
what it's supposed to do.
It's about $27,000 for a single woman when the single filer limit's going to be about $16,000 for a health plan.
Correct.
So
Exactly.
big jump by becoming pregnant.
Exactly.
Level
Yes, I know those
qualify.
numbers intimately. And so she was around 18.5 is what her income was, she anticipated, put her right into the Oregon Health Plan.
Yeah.
Because
And
2 people are at 21 something.
which means you'd have to be at about like 300 or 250, 300% of the FPL to be able to get some sort of tax credit. So this isn't going to be a huge actual tax credit benefit these people are getting. It's mostly about getting onto the insurance at all and opening up that period so they can pay most.
The next one that came in a couple of days later, I already knew that we were going to be looking at, it was her and her husband and the pregnancy, so 3 people. And it did work out that way. So I took, my takeaway was that the federal marketplace does accommodate for a pregnancy.
Sort of, just with the Medicaid side of it.
Only the Medicaid, if it, to send them to the Medicaid.
Well, that's because their income qualified them. In the second case, their income did not qualify them, but the QHP looked at them as a family of 3. Interesting.
So I have a question, and maybe it was just answered, but that among the 10 essential benefits is maternity. Is maternity considered only post-birth? Or is, so maybe that what was discussed. So if you're already covered and you have the 10 essential benefits, then the pregnancy is covered. It's only, so that narrows it somewhat.
And
okay.
I will say that when this started out at the beginning, we had more folks who were still in either transitional plans or plans that didn't include
the 10 essential benefits.
Exactly, and so this really was also a stopgap in terms of if someone was in that, becomes pregnant, and then they still don't have that, they should be able to move into a plan that does. Of course, since things take time, a lot of those have gone away, but.
Gary.
Well, I'm just sitting here thinking, I'm trying to think about COFA, and I'm trying to think about the world where our oyster and rules aside, and we're just brainstorming, and we're not worried about money or rules or anything. How would you make this work? Because the essential issue is there's this small pool of people who actually need access to insurance, right? But they also need access to insurance through the FFM because they want to be eligible for subsidies. Because this is really not about the income level of the women in question.
Right.
It's really about access to insurance.
Exactly.
And so, I mean, if you wanted to take these women outside of the subsidy eligible population and just say, Oregon is the insurance commissioner is going to say that they are a special enrollment period in Oregon, and so insurance companies have to accept these people. And no, they can't get subsidies, but insurance companies have to accept them. That would be one solution, right? And then a second solution could be, I'm just brainstorming.
She's not tickled with that.
I know, right?
So keep going.
No,
Try
well, I'm going back to Claire's question earlier of what have we learned, and so I'm just trying, because there's probably 7 different ways you could do this. Again, putting all rules aside, putting money aside, putting people's preferences aside. I'm actually trying to use what those are.
Oregon could subsidize,
Well, that's just the tax credit, right?
Correct, exactly.
Not the premium, because these people still be expected to pay a premium, but you could subsidize the tax credit.
Interesting.
I have a technical sort of question, which doesn't have to do with the advisability of doing any of this, but just trying to figure out how this would work. So I know that CMS has said that they're not going to alter anything about the way the website works, to enable this to work, but that seems at least conceptually separate from how their rules work around who gets the tax credits and who doesn't. So, I mean, is there some way, because you can only get tax credits if you sign up through the marketplace. And that's kind of the reason why we're even talking about this as a marketplace issue. Is there some way in principle that we could certify people as having enrolled through the marketplace, even if they hadn't actually gone through healthcare.gov, the website, if they qualified for
That's a different direction than I thought you were going to go with that. What's the category that we used for co-op members? Special circumstances? Exceptional circumstances. So conceptually, we could get CMS to agree that in the case of someone from Oregon calling, they could get an exceptional circumstances SCP because they're pregnant.
That is also a really good question.
That in their rule or something, kind of define an exceptional circumstance, for example. So.
But we are talking about the exception.
So the one, I was just going to say, the one thing, Jesse, though, is that the healthcare.gov isn't just it's not just the outward-facing website. The actual website, the real bulk of it is actually the rules engine that determines that APTC amount that connects to this. And I'm not trying to get too in the weeds here, but it actually connects to the IRS, and it connects everywhere, which is where our limitation really comes in. So to generate that tax credit amount is where
it's not about letting them in, it's about the end result when that.
Right, it's not just that facing, exactly, it's the federal subsidy.
We'd have to, I think the key is that exceptional circumstances. There have to be like a letter from Oregon. Probably we'd have to give them a letter saying this person qualifies based upon this Oregon rule, and then they would have to take that and trigger the enrollment period.
I'm just thinking about how they also did this for survivors of domestic violence, where the platform was not changed, but there was a code words that you used in terms of being able to do that, and they did it mid-year, and because they felt like this was an issue. So that I hear them saying no, but I also there's always like there's the workaround. So in terms of that, again, there's issues with how much you ask and expect consumers to be able to present information on why they need these certain things. And in that case, they did make the decision that if someone's coming forward, they should be able to say that and be able to enroll. But something like that. I also, when I saw that come up, I thought that was interesting.
So Hannah and Dawn, as we start to wind down, based on some great brainstorming here, and thank you, Barry, and others for leading us in that. Any ideas for some next steps? Obviously, we didn't develop a specific solution, but maybe just kind of reiterate the ask of this group. I know you're working with the staff, obviously, Hannah, but what would be helpful for us? I think you've gotten some good input, some good affirmation that what you're seeing is what we're experiencing in the market.
Yeah, I definitely think that just keeping this in mind, also in terms, I continue to hear that we need to think of new strategies for getting people in and staying in, and I can't stress enough that over half of pregnancies are unplanned. This is something that will happen to consumers. It is a time when women need to have and want and actually are excited about going to help to the providers, and when we actually can open this up to actually meeting consumers where they are and when they need it, and then thinking about how then once you've opened it up and you've got them, then how do you keep them and how do you make sure that they want to stay? And then thinking about that in terms of again, the overarching goal is a healthy marketplace, but also it is part of our health outcomes and making sure that we can show that by doing innovative things, we're seeing new changes in health outcomes and costs to our healthcare system. So if we think about the high cost of high-risk pregnancies and that to our whole healthcare system by even just one high-risk pregnancy being avoided because of prenatal care, there's a large savings over time. And if we're thinking of we need to be able to show things pretty quick that we can save costs and impact health outcomes, this is one of those, like, this is a one that you can actually put in a little bit of time, and in just 1 year you can probably see differences. And I wish the other states, I hope they're doing well so that they can share with us how it actually has impacted. But just keeping this idea in mind as it's developed, and I know that in thinking about the IT platform, there's a lot of other reasons why we should or shouldn't do it. But again, if we are having our innovation limited because of that, what is the cost to our state now versus the cost to our state in the long run with how we treat people and are looking at our healthcare outcomes? This is also just one of those ideas to keep in mind, that it's not just about like right now, but it's about getting more people in and keeping them healthy.
Well, if this group is interested, I wonder if maybe a good next step would be to actually put down on paper 4 or 5 of the ideas that we've talked about today, and the 1332 waiver Pat mentioned earlier,
yes,
and actually kind of work through what would each one of those look like, what are the pros and cons, and maybe then come bring that back here again and talk through those different options. Because I think as we winnow some of those out, we might find that some are just really undoable because we haven't had more of a chance to really think about it, or that are more doable than we thought too.
And I can't.
Hey Barry, I guess I'd be interested in seeing some data too. I wonder if it'd be worth it to reach out to the Hospital Association and see if they have any data on uninsured people coming in uninsured when they're birthing, just to get an idea of what the magnitude is.
That's a great idea, Ken.
Yeah, I'm sure they
Because ultimately there's a cost here.
Yeah,
and they have that they have all births by payer class, including uninsured.
Good.
So sure they'll have that. And I just want to say I can only speak for myself, but probably some others here. I think your case around the alignment with state health outcomes is really clear, and I don't think we're going to have a lot of debate over that. The question really is, given the context and limitations, how to get from here to there. I appreciate the case you've made. Policy-wise, no one's going to argue with that. I think the challenge is what's the impact.
Yeah, and I definitely don't think that I have like wool over my eyes in terms of that getting consumed. There's a difference between having coverage and being able to have actual expenses. I also know that when women have coverage, they're still spending $12,000 out of pocket for births, and that this is not just the only solution to it, but it is just reducing one of the barriers that we have to women getting, again, when they have insurance, full comprehensive. So this is about birth, but then she'll still remain covered for the rest of her health too. Okay.
I just wanted to clarify there, I kind of implied that there wasn't going to be much in the cost saving area. There is actually between 230 and 50%. There is a narrow band where they are getting the big cost sharing reduction savings on the birth costs and all of that. So there is some of that still happening there. And at a certain point, I feel like, well, we had landed on the middle of whether or not to pursue the federal platform. Once we have COFA, basic health plan, the special enrollment period starts to get up to where we have more innovations we can improve, and that $3 million starts to hurt less for a single program.
Sean, that's a great observation. I would
to avoid the 45-day. One of my concerns, at least last time we visited that, was that when that would be implemented, would be the first 45-day enrollment period. 90 as it stands now. Yeah. If we implemented it next year, or if we started implementing it as now, then you'd be in the second year of the 45-day, which would trigger an automatic re-enrollment for everybody. Everyone would have to re-enroll manually. That was a big concern for agents and community partners, and we're now past that. Some of the barriers towards moving towards the state
I don't want to give
marketplace would be eventually.
I don't want to give Pat heartburn, but to your point about the state platform, you know, you're right, and that's one of the reasons why I think where the committee landed, I can't speak for Pat or the legislature obviously, but where the committee landed was we weren't letting go of the state-based platform, we were deferring it for now, and clearly one of the reasons was the cumulative effect of some of this innovation, some of the programs
starts to slide the scale. So again, discussion for another day, but thank you for keeping that on our radar.
And I would like to say I'd hope that we don't wait till we have a state-based platform to use this. I think Barry's suggestion was great to start going through some of those options and to bring that back to us. I mean, ideally it'd be wonderful to have something we could do next year, 2017. It's a small group, and it seems like it wouldn't be too difficult.
It does seem like it would be remiss of me not to mention that there are some insurance companies who are on the record as very strenuously opposing this. And I don't agree with them, but they will bring those arguments forward if this looks like it's going to happen.
And it's probably selection. It's this idea of waiting until you have an event to go.
Yeah. And it's, well, but it's also that there's the pregnancy triggering event, and then you switch plans again at childbirth, so that you still get a full, so you might only have 4 months with a particular insurer. So there's that piece also. I think part of the conversation that I read about insurers is, would you not allow a person to then choose to have a special enrollment period when they actually gave birth? So that's one thing.
I'll say that the research is showing though that is not really that's not the case. People aren't jumping plans, just like people don't want to have to. They don't even want to have to enroll once a year, and I don't think that they want to enroll every 4 months or 3 months into it. But actually, the research was showing that that is not the case. But although the insurers aren't trying to.
Well, to Ken's earlier request, and I know it wasn't on this point, but any data we can bring forward from other states' experience that maybe that switching is not happening at birth, that would be helpful to ease the fears, because you know, a lot of it is just concern about this disruption and unpredictability.
One other argument that I've heard made a couple of times is a slippery slope argument that basically if pregnancy is a medical condition, and if you create a medical condition as the trigger for an SEP, what's to prevent a cancer diagnosis or something to be a trigger for an SEP down the line, and then then eventually get to a point where enrollment doesn't matter and you can just wait until you're sick to sign up.
No, and I would also say the need. So you talked a lot about the need for insurance, and my clients who are under the age of 40, women, that's why they buy it. I might get pregnant, and so I really feel if you take away that need, then why, you know, I think there could be a big shift in that demographic purchasing a plan for, you know, a calendar year. So
also affecting another person, which is the cancer diagnosis.
True.
So the long-term health outcomes for the newborn is why we give undocumented immigrant
But financially, you could be jeopardizing your family as well, too, by not, you know, if you weren't covered and you have a serious illness diagnosis, too, and emotionally.
Yeah.
Right. This also is another great opportunity for our marketing efforts, and it's one that hadn't occurred to me. We market a lot to people who have children, but we haven't actually really thought about, you know, taking the age population where this is a particular target and really saying 50% of pregnancies are unplanned, you will not be, you know what I mean? So.
Well, there's really a timing component, isn't there? I mean, depending on when you got pregnant, open enrollment does happen in November, December, so you are covered for the pregnancy.
January.
But that may be the birth of the child. And so is there any thought as to a woman finds herself not pregnant but not having insurance, not eligible for Medicaid, because that would be taken care of, that it is in the state's interest to have citizens taken care of, a voucher system say this is for prenatal care, use that, but at open enrollment.
Innovative idea.
Really interesting
The pregnancy-related care, I'd be interested.
Yeah, well, I mean, that seems to me the distinction. The whole reason it comes up as a special enrollment period is it's pregnant.
Yeah, I mean, there's a lot of potential. If the idea is to get somebody hooked in, and then it's like if you are using this and then you make it this far, you get insurance. I mean,
that's much better than my idea, which was move Valentine's Day to September.
We can do that.
I think they move that
right. Good idea.
A big power outage.
Great idea. Super Bowl, what is it?
No, it's New Year's Eve.
New Year's Eve.
Yeah, October 5th was my daughter's birthday, and when I had her, I was looking it up, and that's the most common birthday in the United States because of New Year's Eve. Yeah.
We're moving to New Year's Eve.
Okay. Sounds good.
Just back in that idea, there was
Any holidays.
tax credit for government, or
I'm in bed
if I
by
were
tonight.
to enroll fees, it's going to be 95% of it paid by the Fed.
Maybe they
I'm not
consider
sure.
it as innovation.
Are there grants available?
There are,
I would
the
also
1332 waiver would potentially allow for something like that. I don't know the specifics.
Oh, we have to move money around for something else.
Yeah.
Hannah, closing thoughts?
I'm just saying, if you also don't want, you can put pressure onto Medicaid to even raise that from 190 to meet you, and then there you go. Other states have done that too. Okay, thank you so much.
Okay. We are at 3 o'clock. We've had a great discussion. I always hate to close it out. I enjoy really being here with you all. I think great questions just around the table, great engagement, input. I love the expertise that people bring. Ken on the phone, Maria and Joe, if you're still with us, thank you for toughing it out with us. Thank you for contributing. Any closing thoughts? Yes?
Thank you very much.
Thank you, Maria.
Good discussion. Good discussion.
For the sake of form, ask if there's any public comments on the phone.
Oh.
Seems unlikely, but
Probably just kept me out of jail with that there. Public meeting jail anyway. We do have a public comment period. Unless I turn around and the audience, the chairs are full all of a sudden, we don't appear to have any public commenters here in the room. I don't know if they might potentially be on the phone. Victor, if you're able to tell.
No, I don't see him here, and also we have some instructions on the website for folks if they want to give public comment by phone to contact us.
Okay, appreciate that, but thank you both Jesse and Victor. So let the record show that we invited public comment and we didn't receive any. Okay, that's an important part of our process, so thank you. With that, when's our next meeting, Barry?
Our next meeting is November 9th, and I'm also going to be, I know it feels really early, but I'm going to be sending all of you a calendar opportunity for 2017, just to let you, like, here's the 5 to 7 dates I want to throw out and see what works for that process cemented by October, because I know folks need lots of advance time. Where is the next? Portland.
Great. Closing thoughts. Thank you all. Hannah, thank you for joining us. Lisa, thanks for jumping in. We appreciate it.
No problem. Good to be here.
All righty. We're adjourned.
Thank you.
thank you.
Thanks. Night.
Oh.
Yeah.